Good morning, Joseph Malinga. I'm a researcher and I do a lot of work with the NCD Alliance of East Africa. So we do a lot of policy review and development. And very recently, we launched the East African policy on NCDs. And I'm happy to have been part of the team that contributed to this. Thank you. And I'm happy to be here.
Good morning. I'm Alfred Jasso. I work at the Uganda Cancer Institute in the Department of Community Cancer Services. Currently, I lead that department. I'm also an alumni. Yes. I finished my PhD from South Korea, based at the National Cancer Center.
Yes, good morning. Ochung Guido is my name, and I do work with the National TB Reference Lab. I was part of the 2018 Dr. Lee Jong-wook Fellowship. Thank you.
Good morning. Dennis Nabimanya, my name's Minister of Health and Emergency Medical Services. Thank you.
Yes, good morning, ladies and gentlemen. Sarah Elaete is my name. I'm an epidemiologist working with the Uganda National Institute of Public Health. I'm also an alumna of 2024. You're welcome.
Good morning, everybody. My name is Dr. Celine Jacobs. I am the EMS Program Coordinator for East Africa for Malteser International.
Good morning, ladies and gentlemen. I'm Dr. Mona Alphonse. I'm a consultant surgeon at Masaka and also the KGA president. Thank you.
Hi everyone, my name is Beatrice Orena. Part of the KGA membership and organizing team for this event.
Good morning, everyone. I'm Hashaka Alex, General Secretary, KGA. You're most welcome.
Good morning. Good morning, ladies and gentlemen. My name is Alinda Ruva, Principal Expert Health in the Office of the Prime Minister. At the same time, I'm a KGA alumni, 2021 Health Administrators.
Thank you so much. I think we'll get to know the rest of us during our interaction. I want to hand over to Mr. Kwizera to take on the next program.
Thank you so much, Edward, and thank you so much, members. Now that we know each other, we can proceed. I hope we are comfortable. We see the bottles of water on our desks, on our tables. Those are not the decorations. If you had a nephrologist here, would be advising us. And so please make sure that you don't leave those bottles of water on your desks. They are not, on tables. They are not for decoration. You can take it and then you'll ask for more. They'll give you more water. We used to say that water is a free good when I was growing, but until recently. At this particular moment, I know we are running out of time. We've lost a few minutes, but we will catch up along the way. We will have some briefs from Miss Beatrice Orena, who is the project lead. Please come and give us some briefs, and then we shall proceed. Thank you.
Thank you. I've been advised to use the podium.
Good morning once again. You're all welcome to this event that we've been looking forward to. We've been preparing for you, and we hope that you will enjoy today, and we shall have meaningful discussions in as far as the topic is concerned. So before I go any further, I would like to call upon the organizing team to come here briefly so that people can see you in case they need any help from us. Hurry up, please. Thank you very much for coming in time. All right, so we will introduce briefly what your role is, briefly. All right, so that people know you. So maybe before you introduce, so this is the team, the KGA team that has put together this activity with the support of Coffee Office Uganda, and they will briefly say who they are.
Good morning, ladies and gentlemen. Once again, my name is Alinda Ruva, Principal Health Expert in the Office of the Prime Minister, and I'm in the organizing committee. My role is finance and administration. Thank you.
Dr. Mona Alphonse, KGA President. My role is to oversee all the presentations.
Good morning once again. I'm Alex Hashaka, the General Secretary, KGA Uganda Chapter. I'm all around, so approach me in case of any challenges. Thank you.
So thank you very much. So I think you have seen the people, so you can reach out to them in case you need any help from them. So for today's topic, the Health Forum, turning challenges into opportunities for change. So we are here today. Our intention was to bring different people from different professionalities, the health sector, the policymakers, the researchers, the community leaders, so that we can come together and look at some of the to have an innovative dialogue whereby we're going to discuss some of the issues that we're faced with as a health sector of Uganda. So we know that we've been going through a few challenges that have given us setbacks in different areas where we come from. So we thought that having this meeting with all of us in one room, we would be able to discuss and put together some of the ideas that we have that we think can be able to push our health system further without having to be challenged by a few things that we go through. So I will not waste much time. For today's agenda, we have a few presentations, and we will be able to let you know as we go on. So I would like to hand over to Mr. Kwizera. Thank you.
Thank you so much, Beatrice. I've been a bit brief, and so as we proceed with the agenda, now we know why we are here and who is leading us and who is guiding us. I will have Simon. Simon, please come and give us some introduction about coffee. Is Simon in the room? Are you ready? Just come and take the floor. As Simon's taking us through the introductions, we will, after Simon, I think the commissioner is in, the commissioner EMS, that's emergency services, and emergency medical services will come in after Simon. As Simon prepares, is there anybody who entered in and he didn't introduce himself? Kindly. Anyone? Simon, you need some technical support? Members, those who have just walked in, kindly put up your hand and we would want to know you. If you've just walked in and you haven't introduced yourself, anyone? Yes.
Good morning. My name is Dr. Joseph Oumo. I work with Ministry of Health and Emergency Medical Services. Thank you.
You're most welcome, and you'll get to know us along the way. Yes, sir?
Good morning, ladies and gentlemen. My name is Tom Chove. I work with the Association of Ambulance Professionals Uganda. Glad to be here.
You're most welcome. So Simon, you have your mic and take the podium.
Thank you very much. Good morning, everyone. Protocol observed. Sorry for that delay, but it was just some technical issues on the machines. On behalf of Coffee, I take this opportunity to give the introduction of Coffee projects and what Coffee is doing in Uganda. In Uganda, I hope that most of us know what Coffee is. Coffee is Korea Foundation for International Healthcare. And this is basically a highlight of what I'm going to talk about. Coffee was founded in 2006 as the Korea Foundation for International Healthcare, and it's a government agency affiliated to the Ministry of Health in the Republic of Korea. Coffee provides official development and humanitarian assistance to partner countries around the world, and thereby narrowing down the gap of health inequities, promoting bilateral relations and international cooperation between Korea and our partner countries. And Uganda is one of the partner countries. So COFI maintains 11 overseas offices, including the one of Uganda. We have a country office in Uganda and also in other 10 countries, making it 11 countries. As of today, we have a total budget of about 60 million that we are running. COFI is implementing about 41 projects in 9 countries in Asia, and then also 6 countries in Africa with that budget of about 41.4 million. This is basically a slide to show us the different offices where they are located within the world. In Uganda in particular, I want to say that COFI office was opened in 2017 in partnership with the Ministry of Health and has been here to implement quite a number of activities with a total of about 20 million, implementing projects such as the infectious diseases, capacity building, what we call CHU project, the EMS, cancer, and IED project, and also the WASH project. In 2025, COFI Uganda, with a budget of around 2.7 million, and also 3 Koreans staff that are at COFI Uganda office, with 8 local staff. We are also implementing 5 health projects with the different partners in Uganda. In particular, COFI Uganda acquires the same legal status, acquired the same legal status as an international organization and a diplomatic mission after conclusion of a framework agreement with the Ministry of Foreign Affairs for the establishment of COFI office in Uganda in 2024. So this is basically a slide to show you the different team that I was talking about. These are the staff at COFI Uganda office, headed by Mr. Dohon Kim, the acting country representative, Mr. Jung Sang-hun, Miss Inyong Park. She has been one of our health specialists, but just last month she left, and there's another person who came, Mr. Lee. I hope you will see him soon, and the other local staff. These are some of the ongoing projects in Uganda. We have the Strengthening Health Systems project, which is to prevent, detect, and respond to infectious diseases. We are running this project or implementing this project with the Ministry of Health with a budget of about 8 million, and it is supposed to run from 2022 to 2026, and it's nationwide. We also have the CHU project, the capacity building for community health workers project that is basically in the South Central, in Masaka, Bukomansimbi, Masaka City. And for this project, it has a budget of about 3.3 million USD. It's also a 5-year project. Then we also have the National Cancer Management and Capacity Building Project in Uganda, which is being currently running under the National Cancer Institute at Muvumulago. And then also, we are also supporting, it also works hand in hand with the Cancer Institute at Mbarara, of course being supervised by the Ministry of Health. And this project is supposed to run from 2023 to 2025, so it will stretch to 2026. Then we also have the Dr. Lee Jong-hook, the Dr. Lee Jong-hook Fellowship Program. This is where this is the invitational project where health workers from different institutions have been invited to go to Korea to study different courses. I would say maybe as we go on, I will be showing you that of recent, we also have now, we started with the certificates, but now we also have master's programs running under this project. And it runs countrywide. As of today, we have about over 140 fellows that have gone to Korea to study. And then we also have the Busoga Region Wash Project. It is basically in Masaka, Jinja City, Jinja District, and Iganga. This was it is meant to run from 2025 to 2026. It had a small budget of about 0.23 million USD. These are some of the projects that were run by Coffee or supported by Coffee, but these ones were concluded. Just to give you a highlight of our previous work. We had the first phase of the EMS project, which started in 2017, 2017, and it went up to 2023. It had a budget of that budget, and basically it was in Masaka, Bukoma Nsimbi, and in Kampala. We had the TB project, which ran from 2017 to 2022. We were supporting NTRL and Bukoma Nsimbi, and also the laboratory center. Then we also had the national TB control and capacity building project for South Sudan nationals. This was meant to be for South Sudan, but after opening the country office in Uganda, that project was also supervised by our office, and that was in Sudan, in Arua, and those other places. So it was being supported by the medical molecular labs. Then we also had the strengthening eye health services to prevent blindness in Uganda. This was in Kampala, Entebbe, and in Gulu. Then we had also the MNCH services delivery for South Sudanese refugees and hosting communities, and this was basically in Arua. I was talking about the strengthening and strengthening the health systems to prevent and respond to infectious diseases. This is one of the projects that we are running now. Just to give you more highlights about the projects. This is the ID project. And for this project in particular, as I said, that it is about supporting the surveillance. This project is supposed to run from 2022 to 2026. As I said, that it's a 5-year project. And the total budget for this project is about 80 million. The objectives of this project is, 1, developing communicable diseases control mechanisms in line with the Uganda Uganda health care delivery systems. Then also strengthening infectious disease control through the capacity building of health care workers, and strengthening national, regional, and district capacity in surveillance, epidemiology, and outbreak responses. And also MOH, IS, and the PHE, the UNIPH, EOC, CPHL, and Muvende. These are the implementing partners, those 4 partners down. This is just to show you some of the work that is being done under this project in Muvende and in other places. And then also have the CHU project. As I said, the CHU project, the main goal for this project is to strengthen the community-based health care system through promoting equitable access to care and increase community engagement. It is a 5-year project. That's the budget. The main objective for this project, 1 is to strengthen training, motivation, and performance of the VHTs or the CHUs, so that they can be able to provide healthcare access to the remote areas. And then also to revitalize the governance and leadership structures of the CHUs in line with the decentralized healthcare delivery systems. And also to improve community participation, engagement, and ownership of healthcare programs and sensitize the health matters. Basically, this is to show you some of the activities that are being done under the CHU project. This project involves training VHTs in different courses, including like MCH, CIFA, communicable and non-communicable diseases, how they can manage. And then also, it also includes equipping them. Each VHT in the village received bicycles, and then the supervisors at parish level were given motorcycles, and of course, at national, there were some vehicles that were procured for monitoring. And then this is the cancer project. For the cancer project, as I said, it's running in being supervised by the Ministry of Health and the UCI. The main goal here is to contribute to the reduction of the incidence and the mortality rates of cancer through enhancing cancer management systems in Uganda. It's a 3-year project. The budget is about 3 million, and those are the objectives. One, which is developing the national framework for cancer management system, increasing access to cancer for screening and diagnosis, strengthening the capacity for the cancer management, and also improving the quality of cancer care. These are some of the activities that have been done before, and also the equipment. I mentioned about the Busoga Wash project. I would say that this is a kind of a unique project, if I can say, because for all the other projects that I've mentioned before, when we receive funds, these funds go directly to the partners, and then the partners implement. But for this one, I can say that our office has been coordinating all activities. So it is being done in Busoga region, and as I said, the overall objective is to reduce the incidence rate of waterborne diseases among the target residents to below 3.5. Currently, it's at 4. After conducting the survey, that's what we found. And we are focusing on diarrhea, cholera, dysentery, and typhoid. This project is meant to be for 2 years. It started in January 2025, and we hope to end by 31st of 2026 next year. That is the budget, and those are the goals. For the targeted area, as I mentioned, we have there's Ginger. In Ginger City, some of the activities that are being done is like promoting hand washing facility at Impumude, then setting up drinking water filters at Impumude as well. School-led wash awareness. And then in Iganga, the project also aims at putting up water tank system, the toilet at Bunyiro Primary School, hand wash facilities at Iganga General Hospital, Nakalama, and then also other activities as we have seen. The other project I mentioned about was the Dr. Lee Jong-hook Fellowship Program. This is a project which, as I mentioned, that it's a global training program that aims to strengthen the capacity of health workers in partner countries through systematic and practical health and medical education and trainings. I believe that most of the people in this room right now have gone to Korea or have been in Korea for different activities or for different trainings. And whenever the fellows come back to Uganda, when fellows come back to Uganda, they are given opportunity to arrange some activities. And I believe that's the reason why we are here. This is part of the activities for the fellows who went to Korea, as in they are supported to implement some activities. I want to mention here that the project aims at promoting programs based on partner countries and partner countries' demand, then also enhancing program differentiation in uniqueness, and then also enhancing mutual cooperation with partner countries and improving program outcomes and sustainability. Since 2021, or since Kofi opened the office in Uganda, under this project of the Dr. Lee Jong-hook Fellowship Program, we've had different activities done by the fellows. In 2021, the fellows were supported to implement some activities to conduct some trainings like CIFA training. The fellows this activity was done in Masaka, where they were funded to do some activities. They trained police officers, UPDF, and some bankers. CIFA is community first aid responder. This course basically was aiming at supporting response to emergencies in the community. So that was an activity which was funded by funded by Kofi or under Kga, so that the alumni can exhibit their experience that they acquired from Korea. Then in 2022, we had that another, and also the fellows conducted another program that was the BLS training. And for this one, for the BLS training, they trained some health workers and also the boda riders. The aim also was to still support them to build their capacity in supporting emergency response. And then also in 2023, there was the digital health elderly and the PWs. That was another activities that were also done by the fellows. Still in 2023, there was Tutata, which was I saw Dr. Omona here. This was headed by Dr. Omona, and Tutata became one of the best actual projects that received an award in Korea in 2024. Then in 2024, we had also another 2 projects. One which was on WASH, then also on e-content. These are some of the fellows while they were in Korea and the awards they got after training. These are some of the activities that were conducted by the fellows after coming back. I talked about the CIFA trainings in Masaka. So these are some of the trainings that they conducted, and they did some simulation activities in Masaka. For this slide here, I want to just show you that after implementing the first phase of the EMS project, and based on the good results that were achieved, Kofi decided that they decided to support again the second phase. So we are planning to have a second phase of the EMS project, which we hope that it will start 2026, which is next year, and it will be a 5-year project. The aim is to save lives by enhancing the quality of emergency medical services through healthcare system strengthening. And for this second phase of the EMS project, we hope that the budget will be increased to about $13 million. And the objectives, one is to establish a national ambulance coordination center to support the referral system with the real-time GPS tracking system, and then also to improve health governance and management capacity by developing standards, accreditation, research, and guidelines. And then also to develop digitalized EMS system, program platforms, which will support the EMS system, and then also to train human resource capacity for health workers. So this is going to be the second phase. We hope that the feasibility study was already done. The formative study will be coming soon, early in January, and then the project will commence. This slide basically shows you the planned or the expected areas of implementation, the project sites. By the time we made this plan for the second phase, we believe that the second phase will start from Mbale, Ministry of Health, Masaka Regional Faro, and then up to Mbarara. We hope to have like a belt which will support EMS services. I may need to go into those details. Just this slide here, I wanted to show you that we have our headquarters in Korea. In Uganda, we partner with Coffee Uganda office, but also I wanted to show you the different hierarchy, as in we have Minister of Health and Coffee in Uganda, and these are the different regional. We work with the national institutions, regional institutions, and then also the local governments. For the community, for the CHU project, which I already highlighted, I wanted just to mention here that this year, we had one of the biggest handover of equipment to the VHTs, where we handed over, on this day actually, we handed over about 507 bicycles with 10 motorcycles, and then also we had about 402 smartphones which were given to Masaka City to digitalize the VHT system, reporting system. Because we understand that the ministry officially launched the EHS system, the each system, the digital platform where VHTs report the reports, the data that they collect from the community. So this happened there. And on the same case here, this is basically showing you some of the same things. I don't want to go into much details. It happened at Saza grounds. And then in Bukoma Nsimbi, of course, as I said, that the project is supporting Masaka district, Masaka city, and Masaka city, Masaka and Bukoma Nsimbi. So this was in Bukoma Nsimbi. Also, the VHTs there received those equipments. This project, the Community Health Workers Project is under the Department of Health Promotion, which is being headed by Dr. Kabanda. Here I'm trying to show you Busoga Wash project, which I already highlighted about. And here basically, this was one of the workshops that took place in Jinja. And then also, these are the different activities that were conducted within the Busoga Wash. This was a school-led campaign, still under WASH project. I talked about water supply. This was a water tank that was established at Bulbandi. And then this was a toilet facility that was also set up. At the Iganga General Hospital, there was a donation which was offered to them for the hand washing facility, and then also another hand washing facility at the Nakalama Town Council, at Nakalama Town Board. And this was done between Kofi and also supported by the Office of the Prime Minister. For the cancer project, this slide here basically is to show us that an agreement was signed between Korea with the Ministry of Health, which was represented by our permanent secretary, Dr. Diana. And this happened in Korea when she visited Kofi in Korea. So this agreement was signed on 28th of February, 2025. Quite a number of equipments were offered. So we are here. I wanted to say that Kofi has donated the screening machines, which were worth 2.3 billion to the Uganda Cancer Institute. And these are supporting the different services that are being offered by the Cancer Institute. These were also some of the other equipments that were donated. Some are supporting the Cancer Institute of Mulago and also the Cancer Institute of Mbarara. I wanted to mention here that for Dr. Lee Jong-hook Fellowship Program, we've had quite a number of programs that have been conducted over time. For 2025 courses, we had these are the different courses that we had for that duration, and these are the number of fellows that were sent to Korea. So we had 17 health workers who were sent to Korea in 2025 for those different courses. Among the courses, as I mentioned earlier, actually we sent 4 people for a 2-year course, master's, graduate courses in biomedical services, nursing, health policy, and biomedical engineering. So making it about that number. These are some of the, for this slide, these are some of the activities that were done. Some fellows who went for the training. And then for the infectious diseases project, also, these are some of the activities that were done. And then we also had engagements with different partners. I beg to end here. Thank you.
Thank you so much, Simon, for taking us through the various projects that Coffee is doing and giving us the perspective of Coffee. We appreciate that you've taken us through all, and then various and so many projects. We now know that actually Coffee is doing a lot of work in our country since 2006. Maybe as we get along, we'll have to discuss this presentation, but maybe what I have noted here is that we've looked basically on the outputs. We will definitely be wanting to know whether somewhere we have maybe probably gotten some outcomes along the way. But at this particular moment, from your presentation, we basically see that we are still at the output level. And I want to see, because there's a lot of investment that has been put into our country in the health sector, and we think we should be moving some, we should be counting, not protecting, but counting the gains before we go to protection. We'd like to have the Commissioner, Emergency Medical Services, to give us perspective, and then we'll be breaking for tea or coffee. Sure. You're introduced. Sorry? Do you have it at the Secretariat? Okay, fine.
Thank you, MC, Mr. Kwezira. Dr. John Baptist Suwanyaye, Nambohe, commonly called JB, and I work as the head of emergency medical services at the Ministry of Health. I also, I think, went to Korea 2018, there when we were starting the department of EMS, the one for high executive leaders orientation, and we were with the Dr. Onyachi. That time we was still at at Masaka, and Dr. Kalanzi, and the one of Butenga. So we were there for a short while to just get the orientation, which helped us to manage the, okay. Yes, we wanted to talk about the policies, the health policies which are currently related to EMS and the priorities which we are having. As you all know, Emergency Medical Services Department is a new area in the Ministry of Health, and I'm glad to have been the first commissioner to be appointed in that role. I think I came to ministry in 2017 when EMS department was then thought about. But currently we have been able to move, and the biggest document in the country right now is the National Development Plan 4, which is one of the Vision 2040 strategic areas. And in here we do exist. The first document which came out was the National Development Plan 4 Cabinet Strategic Directive. When you check 75/7, you are going to see that it talks about strengthening emergency services, national ambulance system, and the referral system. Then the National Development Plan 4, Chapter 17, Human Capital Development, Objective 3.13C, NDP 4, PIAP 31214, all those are speaking about emergency medical services. And that is the highest document in which we have managed. The NDP 3, there was a statement on it, but NDP 1 and NDP 2, we did not have any existence in those documents. Then we have the Ministry of Health Strategic Plan, Chapter 3.6, Objective 3, 3.9. Then also the Budget Strategy 2026-27, Priority Intervention 53.5 is speaking about that. You'll check also the Ministerial Policy Statement of 2025-2026, 5.2 and 6.4. It speaks about functionalizing HDUs, ICUs in regional referral hospitals and improving referral coordination and ambulance system. We also have a statement by the minister there which shows that the EMS system is still weak in the country, and this has affected the service provision at regional referral hospitals and the national referral hospitals. It contributes to overuse or overutilization of services at that level. Now the direct document which we have is the EMS policy, and it has I'll go in detail in the next slide, but it has a mission statement of reducing mortality and morbidity through ensuring high quality, safe and patient-centered out of hospital and in hospital emergency care services that meet the needs of the population. There are areas in the NDP4 and the ministerial policy statements which are not directly mentioning emergency care, but when you look through them, you are able to understand areas of emergency care which we focus on. Like in the ministerial policy statement, you check those pages in which it indicates about other conditions. Then we have like number 6, which is prevent and control non-communicable diseases. And here you know that non-communicable diseases have a big contribution to emergency care burden. We have also number 7, which is to improve the functionality of the health system to deliver quality and affordable preventive, promotive, curative, and palliative healthcare services. This, again, EMS works across the continuum, right from health promotion to rehabilitative services. That continuum, health promotion, health prevention, curative, palliative care, and rehabilitative care, all that continuum. The other one, 8, is on improved maternal, adolescent, and child health. In our analysis, we have seen that there is a big contribution which we make in maternal health. About 60% of our interventions actually are on delay 2. So we facilitate the ability of these mothers with the obstetric emergencies to reach the next level of intervention, especially the comprehensive obstetric and neonatal emergency care facilities. Now, in the National EMS Policy 2021, the key areas are governance and leadership, ambulance and pre-hospital, emergency care units, human resources, communication dispatch, and coordination. And the policy intent then is to reduce preventable death and disability, ensuring timely and coordinated emergency response, and also to improve the quality of emergency and trauma care. When you receive the burden of disease, you are going to see the contribution of trauma. Currently, it is now, it has risen. 5 years ago, it was not among the top 10, but now it ranges between the 3rd and 5th leading cause of mortality in the country. So it's a big problem. And they change, if you look at the statistics, from 2015-16, we had about 53,000 cases of road traffic injuries. But as I speak now, we are speaking about 164,000 road traffic injuries. That is an increase of more than 300%, which is a big problem. The other part is to integrate EMS across all levels of healthcare. We developed the EMS strategic plan, which we have, it was supposed to end in 2025, I think it was June 2025, but we extended it by 1 year. Oh, sorry. Sorry. This is the problem of using two documents. Okay, this is where I am. Okay, that was policy intent. In the strategic plan, I was informing you that it was to end in June of 2025, but because of delay in developing the next one, we have extended it for 1 year to 2026. We hope by that time we'll have developed a follow-on. And in it is strengthen pre-hospital emergency care, strengthen facility-based emergency care, operationalize the 912 national emergency line, standardize emergency care units across Uganda, and build EMS workforce capacity. And I'll comment on two areas there. To operationalize the 912, we are in advanced stages with this, and we think that by end of this December, we should be able to have a short code 912 functional. In terms of building the workforce, you have seen, as we speak now, we initiated the training of emergency medicine physicians around 2018, Barara University, Makerere, and recently also Uganda Matters University, this Zambia campus. But so far the outputs have been about 29 emergency physicians, and recently we also started the training for paramedics, and we have had the first graduation of emergency care assistants, and we are going to have the diploma holders soon, and we managed to get scholarships for some of those people. We'd like to establish regional dispatch centers, define EMS standards and operational protocols, referral networks, and also EMS training programs and competence pathways. These, again, are the current priorities. We would like to finalize and pass the pre-hospital ambulance service regulations. We got a cabinet directive on the pre-hospital services because there are a lot of players in this space, and I think some of you have seen that politicians, when they are campaigning, they paint in a vehicle and write their ambulance, and the things it does, you cannot even really bring them so close to emergency response. But they are using it, they know the population feels that they need an ambulance, so when he has labeled it, it will become. So when we develop these regulations, it will largely help us. We would like to institutionalize EMS in the Ministry of Health governance structures. It exists now, but it's not robust. And also enforce ambulance standards in both public and private. Would like to have the National Call and Dispatch Center funded, and that proposal which Simon, the project which Simon was speaking about for the phase 2, you saw, some of you who could have been keen, you saw the first area there is having the National EMS Coordination Center. And with that answers to that area where we would like to have the National Call and Dispatch Center. Of course, we are starting at a minimal level, but if those resources become available, we would like, and Mulago Hospital was judicious enough, they gave us space on the hill, that place near the SHOs. There is a space there where the other time we had built an area for Ebola isolation, but next to it, we have land there where we shall have a robust structure. We would like to standardize emergency readiness in emergency care units nationwide. And also the issue of departmental mandates. Of course, it came in, I think Dr. Mona would have deleted it, but I decided to leave it for some of our thoughts. But what's there is that there is a lot. When nothing is being done, you don't realize that there is a conflict or struggle. It comes only when something is being done. Then you realize, hey, so-and-so says, but you are stepping on my toes. So-and-so says, so it's very good for us to have a well-defined area. And but it is something. The same thing with the opium. We are working very well with most of these institutions, OPM, police, KCCA, the military. The military, you know, that's running our marine ambulance response system. In another project where we are going to start the aeromedical service, again, that proposal, because we are still weak, we have to accept when we are weak, we say we are weak so that we receive some support. So in the proposal, what we put there for the aeromedical is, for the beginning, we want to utilize the Uganda People's Defense Air Force in running the civilian aeromedical service. And if we do that, we are able to start off sooner than later. Then coordination, the EMS department, again, we have proposed to widen the structure to that effect. Would like to ensure accountability and oversight structures. There are some legal gaps which we note. You are welcome. We are WHO representative. Thank you. Good. Legal gaps. The EMS regulations. This is what I spoke to, but we realized in Korea there is an EMS Act. For some of you who followed that process. But for us here, it will be regulations riding on the Public Health Act and also on the Traffic and Road Safety Act. Those are our big documents. Then in it, we are going to develop this. And I think Maria will tell you later, we had something on regulations, which I think we have not been able to popularize, but we need all of you to have a read through and see. Then Good Samaritan regulations, private ambulance services, this, like the overall private sector, the regulations are limited. Some are very good, some are very poor. Then the legal structure for EMT and paramedical professionalization. Here we are still discussing with the Uganda Allied Health Professional Council, but there is positivity that everything will be streamlined. We are in discussions. Even yesterday when I was at the JRM, I met the chairman there, and they had received the PSC's communication on streamlining that. We have ambulance misuse. I think all of you have seen, sometimes we have arrested some people, they are carrying Supermatch. You know Supermatch, that it is a very popular, I think, smoking thing, cigarettes. And then there is another one who had packed very highly recreative things. They were phones, tablets, but all were covered like they are patients in the ambulance. And this was a new ambulance. And he was driving, you know, those full lights of give me way, this is a red patient. So he kept moving all the way from Arua. He passed all until someone said, but it doesn't look like he has a patient. This is speed. So one traffic officer stopped. He never wanted to stop. They insisted and he stopped. But when he stopped, one person jumped out and ran away to check. There were those items. And they were. So we have a lot of abuse and we have to do something about it. We need a national ambulance registry. Again, even the cabinet has given us a directive on this. Emergency medicine HR deployments, this is for our advocacy, and some of you from various institutions, please prioritize in your institutions recruitment of these people. Emergency medicine physicians, the paramedics, they have a role to play. They have the space. The emergency nurses, all these people have a space which we must, as necessity, make sure. Weak data collection and reporting, this we have kept improving. Now where the biggest gap is in the pre-hospital data. It used not to appear in the HMIS, but we'd like to have that linkage on the pre-hospital. When people have worked at the scene, they have worked during transportation. How do we capture this in the system? For health facility, it is okay because we developed the tools and it is having a fit. The other time we were talking about drowning, drowning prevention, drowning death, and so on. How do we capture this? We need that overall linkage. Okay. Did I press more than what I needed to do? Okay, these are the proposed areas of intervention. Probably what I would like to state more on is the issue of in-service training, which we would like to scale up. We are in advanced stages of a proposal which will be funded by WHO for scaling up back to Tata, which Dr. Mona will be giving you more, but we would like it to be scaled up so that we deal with the trauma. Then other trainings which we have mentioned. I think even Makerere University is starting a master's in emergency nursing, improving emergency readiness at Health Center 4. Then the phase 3 will have national coverage, integration, fully functional 912. This 912, which we shall open this December, will be covering majorly Kampala and partly Arua, Jinja. But we hope with the project which Simon talked about, we can deepen that area. We have also Maritiza International in Ankole area. We hope we can utilize that, and also a GNF to widen, so that at the end we'd like to have a national coverage integration of a fully functional 912 system. And a nationwide standards enforcement. Would like to have EMS fully integrated right from the pre-hospital up to the hospital level. I commented on drowning prevention data integration, then the public-private partnership. And then the role of innovation. Innovation is very important, and when we have the local innovations, they take care of the contextual needs, and also sometimes even the foreign models, we may fail to fit them within our national level. We would like this to be developed, we improve them, adopt, and they are easily sustainable. And this will help us to build national emergency care identity. A few comments about the Tutata. We want to appreciate the team You saw this is our flagship. We'd like to appreciate the team. In 2024, they made us very proud. All of you members of KGA, you remember that time when out of all the countries attending and you are the best. How did you feel? The feeling is something is being done. We are coming from nowhere to somewhere where we are being recognized. So it is a first locally developed trauma algorithm, and it standardizes assessment and treatment. It supports triage and early intervention, and it is scalable at all levels of care, and it's ready for the national adoption. I can say that it's already part of the national system, and we think that when resources are available, we are going to have the rollout across the country. And you would look at the annual health sector performance report for this year, which the minister released yesterday. The minister was represented by the PS. They released that report yesterday. You will see in that report the issues we are discussing on trauma. So when we talk about the Uganda trauma and treatment algorithm, we are focusing on addressing one of the big problems in the country. Human resource issues, I've already mentioned these areas. We would like recruitment of these cadres. We would like to institutionalize emergency medicine training. We would like to strengthen the district ambulance teams through in-service trainings. We would like also to have a faculty of trainers, which I think Dr. Doreen, when she's here, she's best placed to talk about the faculty of trainers. But we appreciate what Seed Global has also done in building that team. Now, in summary, these are the key areas: improved response at the scene. It is our focus on post-crash care, mass gathering. Some of you, I think we invited you to participate in some mass gatherings. WHO supported us to develop the health management framework for mass gatherings. And it is focuses on sports, religious gatherings like what you see in Namugongo, sports like you saw we participated in Chan. We are now preparing for AFCON. Then also culture, Kabakaran, that side of mine, even year we have got to reduce some of the skins of our boys. So it is a big function. Then in Karamoja, there is a cultural gala which brings all these people together. So, but our role as EMS is to ensure that all that is done in safety. On it is also political gatherings. We are now in an election period. And I want to appreciate our teams there. They have been supportive for the presidential campaigns. There was a big accident, I think it was in Oyam, where the tent collapsed on people, but all of them were managed. There were some who fractured, but we did not lose any person. So that is, then we have drowning prevention. Drowning is a big thing, but we have not yet, because data is not well captured. We need to do a lot in this area. Then the functional call and dispatch system, as I said already, the national and the regional. The national, we are hoping with the project of coffee phase 2, we are going to deal with the national one. The regional one, so far we have Arua near completion, Mbale, Mbarara. We have also equipping of Jinja, Yumbe, and also the isolation unit. We would like to have a responsive system. Road, you know how much we have done. Marine, we have done something. We are now establishing the air, I think in 2027. And that project is in advanced stages. It is moving together with the one of Cancer Institute. I think Cancer, you are mobilizing a lot of money, but we are moving. For us, it is literal, but we are moving together. Today, Minister of Finance, we are asking me for a report on it. Then functional A&E, we have already mentioned. Then disaster response, we always work with the OPM, epidemic disease response, mass casualty, climate change. All these have in climate change, you saw recently the landslides in Bukwo and Kweni, where our presence was required. These virtually I've talked through them. The service regulations, operationalize the National Dispatch Center, adequate resources for EMS, and I want you to join me to thank government, because when I talk about, I'm still advocating for more resources. Recently in the supplementary, of course, it's aimed at doing other very important things, but I found that the National Ambulance Operation System was part of that. So I will ask you to give a hand clap to government, and you say, please add more. They gave us 10 billion, and which we are going to utilize. We were operating on about 4 billion for the whole country. And yet our estimates are 27 billion to run the national ambulance system. Right now, that may bring us, I don't know whether it is going to be there next year, but we appreciate that it has been given now. And then to establish sustainable EMS financing, which is user in budget, institutionalize the training. Yeah. Now I wanted to show you this one, that the man of the heart during the launch of the marine ambulance system, when he signed our plug, that is what he wrote. He wrote, "At last, good." And I asked my team to write, and they were writing so many pages about what the president made by "at last good." If you were the one being asked to interpret the president's statement, "at last good," what would you say? That is food for thought. Thank you so much. That's the end, but I ask you that I'll be leaving, because while I was seated there, the warnings about being absent from JRM were being serious. I would ask the organizers, Dr. Omona, we need to be in sync with other national activities. When we have a big activity like JRM, it's very hard for us to be able to get the top people. Even Christina, I don't know how you have got her to even be here. It is difficult when we have the JRM, because it is like setting the policy direction for next year. So I think next year, let us be more realigned. Thank you so much. Good.
Thank you so much for elaborate presentation and for the advice that you bring at the end. Indeed, you mentioned it. I think it came in your presentation about issues about the departments. I don't think it was some point kind of clashing. But I want to invite the people who have presented to come and take the front chairs, and then we can have a few questions before break. We go for a break. We need Beatrice come forward. He talked about Kga, and then Simon and JB. Yes, JB, take chairs, and then any other person I haven't mentioned? So I will have maybe I'll start with Beatrice. Is Beatrice in the room? Okay. All right, so I have Simon. When you were presenting, I must say, I became a bit jealous. You presented all the projects or the activities. I told you I work with Ugandan Uncommunicable Disease Alliance. Yes, I know there is a lot of work that's done with the Uganda Cancer Institute, but that's not enough. NCDs today account for about, if you add injuries that I was talking about 46% of all death in the country, and the numbers could even be more. And you've done a lot of investments in a health system. And I would think that probably, can't we think of 40%, 46% of your investment also going to the NCD prevention and control? So when are you venturing or supporting the NCD services? Because you may give the services to everybody, but at the end of it all, they will suffer an NCD, and whatever you've invested in goes down. But I just want to know when you invest into NCD prevention and control. And then, of course, the other question I have for JB. JB, you've given us the strategies and the policies at the Ministry of Health, and looking at EMS. But my question is, I've been to the most health facilities in the country, government health facilities. You may buy ambulances, but where does this ambulance deliver me? Because if you're talking about emergencies, we also, you started with the NDP, the National Development Plan 4. So are we talking about, even then, I may be evacuated from, say, on Masaka Road, somewhere in Masaka, and I'm brought, maybe from, you can even be evacuated from Chisoro, and in an ambulance. But then you find a traffic jam between Sanji and Kampala, or maybe on Ginger Road, wherever you are, and you die in between there. Are you looking at that? Are you just looking at the emergencies and maybe highway crashes and then delivering people then? So the other issue is, you talked about the healthcare providers. Those on that you're training for emergency services. Are you also looking at other healthcare providers in this to ensure that even when the emergency healthcare providers are trained and they're able to handle emergencies, but where they work and the other team they work, healthcare workers work as a team. You may have a good doctor, a good emergency nurse, but by the time you get there, the radiology system is not working. And then they cannot proceed. The lab person is not there. And then they cannot proceed beyond when the person needed all those services. So are we also looking at it holistically? Let's not hide in the recent issue of talking about integration. Let's look at the challenges that we have. So unless I don't know where Beatrice is, I also wanted to press a question to Beatrice about the Kga, how people maybe get the opportunities of becoming alumni. Thank you. And if you answer those questions, then we'll also require that the people in our group can also ask. Please forward your questions directly so that they can handle them at once, and then we'll break. Thank you. And that light is.
Thank you so much, our presenters. It has been nice hearing from you. To Simon, we realize that there is a ongoing project on strengthening the health system to prevent and respond to infectious diseases. We are, us as TB laboratory, we are not fearing you. We know, we acknowledge the support you gave us, but it's like you have abandoned us in subsequent project, yet TB is among the infectious diseases. Then to EMS, there is delay in pickup of accident victims. What is the challenge and what is being done to address these issues? We recently saw people dying in accidents. The ambulances do take a long time to reach them. What is being done at ministry head level? Then we realize that most of these accidents are mainly due to our poor roads. Is there any link between MOH, EMS, and UNRWA? Thank you.
Okay, can we respond to the questions? Maybe we'll start with Beatrice.
Thank you so much, Mr. Kwizera. So the question you asked was why, how can someone get the opportunity to become a KGA alumni, right? Yes, so every year, Kofi sends out an invitational program to different institutions where they are having the projects. So for example, infectious diseases, health administrators at the high level program. So this call is made every year to those institutions, and then the institutions nominate people who are fit to go for that training. So these people go to Korea for different periods. If it is high level, it ranges from 2 weeks to let's say a month. And then if it is other programs, range from 3 months to 6 months. So we go to Korea, we go and study on different courses. And then when we come back, we develop action plans after the training that we're going to implement here in the country. Some of the action plans that we implement are actually these KGA projects. So these projects are meant to facilitate the people who come back from Korea to implement the action plans they have developed in the country. Yes, so through institutions, that is how you can become an alumni.
So would I be right to say that people are attached to the projects that come?
Could you rephrase that?
Would I be right,
yes,
maybe to think or believe that the projects come first, then the funded institutions, organizations nominate people when the announcement comes so that they go and are trained, and then they are attached to the very projects that are ongoing?
Okay, so we have someone from Kofi here. He can respond to that.
All right then. So straight to Simon.
Thank you very much. Actually, I think I will start with that question. To support Beatrice on answering that question, first of all, I would say your question is yes, but also more than that. Some courses are designed to support the running projects, but for some courses, they are designed based on the interests of, I can say, the ministry. Because every year, COF headquarters sends us an outline of the different programs that are available at the headquarters, and then we always bring that list to, or we bring that outline to the ministry to select which courses would be of preference based on the situation. So then after that, once the programs are approved, the approved programs, they again share them with us here at the country office. And when we are going to invite for invitational courses, a letter comes from the headquarters with the different courses that, you know, based on what you planned for, or based on what the plan that was made earlier, these are the different courses that are available. Now we ask the ministry, through the ministry can reach out to the different institutions where, actually of recent, before we used to contact the institutions directly, but of recent, the approach now somewhat like changed. We send that request to the ministry, and now it's upon the ministry to select the people based on the institutions where they feel there is need. That's what I can say. Thank you very much. And then the other two questions I got, one is when are we going to focus on the prevention and control, especially for the NCDs? I would say that
beyond cancer.
Beyond cancer. I would say that first of all, as coffee, sometimes I can say we may not determine exactly what we are going to implement here, but whatever project that we do support is based on the dialogue between ministry or between the partners and the coffee. Yes, as coffee, we may have our interests as well as development partners, but many times what comes on board, what we go ahead and fund is based on the dialogue between coffee and the ministry. Now, for example, for this cancer program, yes, at coffee side, we had interest in something to support NCD. But when we went to approach to the ministry, at that time when this proposal was being drafted, we noted that we were informed that there was a gap for cancer, especially for, even as cancer, not all cancers, we strategically went for the cervical cancer. So that's how we went into that. But what I can say still is that coffee is open to support more on this, and we have much interest in supporting the NCD. Maybe going forward, we shall have more discussions to see how we can expand on this. Because we even have hopes that maybe after the first phase of the cancer project that is running right now, there is hope to have a second phase. So in case, as we are going to have the second phase, in case that second phase comes, if it's a given opportunity, we can expand and see how we can add on other conditions that can be managed as well. Then the second question was about, somebody mentioned that for infectious diseases, they are not feeling, coffee supported the TB before, but currently we are not. I think that was the question. For the infectious disease that is running right now, it is more, actually we are supporting the infectious diseases under the Department of Surveillance, which is in the Ministry of Health. And the focus is more on the detection, prevention and control. I know TB is among these, it should be among these, but the priority that was given by ministry, I think was focused more on surveillance. Then much effort also is being done on the Isanda laboratory, which is at CPHL, and then also, basically I would say under that, but to expand maybe like to NTRL, yes, we've worked with NTRL, and I know we made quite some good investment there. But this project in particular was more focused on surveillance, and where we are operating currently, all the partners we are working with, these were selected by the ministry. So maybe if we could work on this project currently and it also gives us good results, I believe ministry can still decide and maybe can still present a request to give a hand to NTRL if you really feel that there's a gap as of now. Thank you.
Okay.
Good. Thank you, Mr. Kwezel. Excuse a bit. Sometimes I react to some of this good air which flows around. That is why you will see my voice becoming small. Okay. You have rightly indicated that you get worried when you see all these ambulances ferrying patients and they are taking to what you think are inadequately functional emergency units.
I actually don't think I know.
You know. Now, of course, as I said before, emergency care was not pulled out as an area of focus originally. People thought that you can improve the healthcare system. You invest in various areas, human resource, infrastructure, constructions, and the system itself sets up to provide for emergency care. But we all must note that in order for you to provide emergency care, you have got to be intentional. Intentional, you must improve those key areas which make issues better. In 2019, WHO, during the World Health Assembly, 72, they made the resolution 7216, in which they urged the member states to focus on improving emergency care for the acutely ill and injured. Why? Because they realized that most of the people were dying because this system was weak. You can imagine all the investments we have been having over time, but you go to an accident and emergency unit and you find yourself feeling inadequately being attended to. So this is the reason why we came up with focusing ourselves to improving these areas. With various support, with one of the areas was equipping. The equipping of accident and emergency units was minimal. You could reach, and even diagnostic equipment could be a problem. And during COVID-19, we had got to focus on improving some of those diagnostics. And we want to thank some of the partners who supported in getting equipment to these areas. Up to 172 health units, emergency units, we equipped them. Now, we have also done in-service training to help provide case scales in basic emergency care to selected staff, but we have not yet far. There are also basic life support courses which are taking place, but we have covered less than 10% of the health workforce. Then the other gap has been issue of emergency medicines. Emergency medicines are, sometimes they are more expensive. So people prefer to buy other essential medicines and ignore this life-saving. So sometimes you reach and maybe you just needed 50% dextrose and it is not available. Yet you don't have more than 5 minutes in someone with hypoglycemia. You reach and probably this one has been injured and is bleeding. You needed to stop the bleed. Maybe you just need the gauze, you need what? And you are asking the patient to go and buy, but you know it's spitting. Probably you needed to intervene at that point in time. You need your emergency theater. Most of the hospitals, that emergency theater in the casualty unit is about 20 to 30% operational. These are some of the areas which we are focusing on now. In 2023, we had to review the staffing structure to just provide for staff who are dedicated to that area. You can imagine if I'm a nurse, I've been posted to handle outreach, immunization, and so on. And suddenly, my boss puts me in the emergency unit. And that day, I am receiving a convulsing patient who requires immediate care. I have no time to go and check how do I manage this one. So we are saying that we need staff to be trained and also to remain in these units. When you train people in emergency care, let them remain in that department, because this skill, you need to utilize it and you need to have it very close to your finger so that you are able to dispense. But what we have now is the issue. One person will be prepared today and is moved away. You bring someone and you reach, doesn't know what to do. So we are in that, and we have planned going forward in the next 5 years we may improve. I agree with you that even you assess from yourself. If you got into an emergency right now, where do you want to go first? Now from that, when you ask yourself that question, the answer you give tells you whether we are doing well or bad. But it is us who must improve the system, nobody else. It is us. We should not think that there is someone somewhere seated, the minister, the PS seated somewhere who will improve the system. It is us who would improve the system. It is us to say there is this gap. And what our assessments have indicated, our advocacy, is that the gap is there and we must fill it. We are working closely with Dr. Ronnie, who is the head of clinical services, to see that we improve. In one of the projects which we have written recently, we are going to equip 52 highway health units with emergency equipment to help the health workers have what to use. And then we are going to also train these health workers to deepen their emergency care skills. Then this next one on traffic jam is a difficult one. One is that the ambulances have a provision in the Traffic and Road Safety Act. Maria, is it 2020 or 2022? 2020, as amended 2020. In that act, I forget, I think 70, either it is 65 or 72, that section gives a right of way for ambulance vehicles. So ambulance vehicles have a right of way, but all of us are drivers here in Kampala. Sometimes that right of way is denied by the road itself. You find that the whole road is packed and you are saying right of way. So the ambulance person is stuck within. So what are we doing with this? We realized that if you did a lot at the scene, stabilized this patient, you will be able to buy more hours as you transport this patient for definitive care. And this is what we are doing to train health workers to provide on-scene care fair enough, and when you load this patient in the ambulance, is stable, so that there is no need to do a scoop and run. You remember previously when EMS was being started, it was a scoop and run. You would remember the man of cholera in UK who started the ambulance system. Dr. Omo, remind me that doctor. Oh, but all of you public health professionals, remind me that doctor who, it was a cholera outbreak in UK, and people were dying, severe dehydration due to diarrhea. Then he said these people can survive when we give fluids, but we couldn't give fluids in the field. So one thing was to pick this severely dehydrated patient quickly, put on a cart and run to hospital. And if he reaches alive, they get a line, they saved those patients. Now we are not still in that phase. We are now in a phase where I can access an IV line at the scene, rehydrate, stabilize, and place this patient and transport to hospital for definitive care. Why do we want to have paramedics on board? Is that they have been trained how to provide care in transit. Of course, I have also a problem. My ambulance drivers, because I don't have fully professional ambulance drivers, sometimes they are driving at 100 plus. I have been interacting with them, asking them, why do you drive at 100? There is no way a paramedic behind there will provide care if for you, you are moving at a speed where he or she cannot assess and provide treatment to a patient. But we are dealing with that. We are training people. We would like to have first aid clear. We would like to have professional first responder care better. We would like transportation care better. And we would like when they reach the hospital, that person who is welcoming you at the accident and emergency units should be knowledgeable, should be willing, should have the attitude for care. Sometimes it's not about only skills, it is also attitude. Someone says, oh, mutekao. It may not be lacking things, but the mindset is not the one of emergency care. So we are working also with the Minister of Works and Transport. As you know, Mr. Kweza, the Minister of Works and Transport heads this area of road safety. We are players. We head the Pillar 5, which is post-crash response. But before Pillar 5, you have the issue of roads. How wide are our roads? How safe are our roads? Do our roads provide for emergency vehicles? This is Ministry of Works. How are our drivers? The ophthalmologists, the tool requires us to assess these drivers' eyesight. Some of these drivers are epileptic. Some have diabetes. We have got to know that diabetes is controlled, because if someone becomes hypoglycemic during the time he's driving, then it's a problem. Or you get an epileptic fit. There is this petit mal, which it is only you who is getting those absent seizures. The rest of the people think you're okay. Then you see someone going off-road. So we'd like that area. Then the issue of awards of these driving permits, all that contributes to this big problem which we are seeing. But we shall have another day to discuss road safety per se. We have had good trainings in road safety, and we have good support from Maria used to work with us, but she went into bigger support, global level, global road safety incubator. She's a manager there, and when Dr. Omona approaches her, we can have a special one for road safety.
so that we can be able to place something. The last part is on a issue of emergency care professionals, why we are not considering others. In our package, we consider the other teams, and I think back specifically, we go and pick out and have training for these people. I'll find out more about our focus on radiology and laboratory, and then discuss with Dr. Susan how we can be able to deal with it. And it is a big disadvantage. You come as an emergency and they tell you go for X-ray, and you reach the X-ray unit, it's non-functional. Now genda muandegea. You go and reach, they say now you need to pay this money. Oh, I did not come with money. But you see, it is possible for us to have our emergency units, radiology and emergency laboratories working, but that requires focus, and we can be able to do it. Delay in evacuation of accident. Oh, this is about response time. Members, we are coming from far. In 2020, we only had 2% of standard ambulance vehicle coverage in the country. It's just last year that we are reaching, this year, we are reaching 60% of coverage. So when we speak about the response limited, is because you already have fewer investment. But as we increase the investment, we shall do better. The government of Uganda provides annually about 7 billion shillings to Uganda Red Cross to provide ambulance response on our roads. And we are supporting 21 ambulances under Uganda Red Cross for response on the highway. I mention this because sometimes you people may think that government is not doing anything. Because when you see Red Cross, you start thinking that's not government. Government works using all this level of partnerships. But it is 21, and we need more than that. When we did an assessment of hotspots for accidents, there are 250 in the country. And we need to see that there is emergency response at each of those levels. But we are increasing the number of ambulances, and our response time will improve. Then issues of poor roads. UNRA has also established that whenever they make a new road, because we complain that the roads are bad and we are getting accidents. When they make a new road, accidents increase. Have you realized that? Whenever they make a new road, accidents on that road increase. So we requested them to package something for emergency response, and that is what they are doing. Thank you, Chair. Chair, there was someone there. Thank
okay, before the person comes in, I think you have handled that. Maybe one other thing that I want you to tell us. Yes, you are buying the ambulances, and we appreciate that. But the management of the ambulances, I come as a money emergency. I go to the hospital, they are referring me to the next level. Then they say, okay, fine, the ambulance is there. Then they say, no fuel. Then they also say, you have to pay the per diem of the driver. And the funny thing, they don't tell you direct. You just see people doing like this, zigzagging, and nobody tells you. So why don't you publish and know that if an ambulance is there, there is a cost for the patient or the person who's being referred. So by the time, even when I'm an emergency, even when I'm around, I know that the ambulance is supposed to be paid for. And that's the challenge you have as these ambulances that you put in place. Maybe that one you can handle it with another issue. Since now you are a commissioner, and I want to take you to the issue of management. You started with policies. For us from the civil society side, we have a challenge that there is a delay in approving some of the policy documents at the Ministry of Health. And you know some of these documents are fundraising tools for us. Until they are in place, then we cannot have partners and we cannot have the resources. So we need to know why do you not may take longer to have these documents, approved. Yet, if you look at the documents, the policy documents that we have in our country, even researchers, and look at the recommendations, if we had them approved, if we use them without developing others, we would be at the moon. But we keep making many, pile them, not approving them, not looking at the recommendations. So that's something that we should handle now as a commissioner at that level in the Ministry of Health. Somebody has a question?
Okay, thank you, Chair. I'll do quick as our time is becoming bad. The one on approval of documents, I'll say I'll have to bring this to the attention of the Director General. One thing is that the ministry usually fast tracks this, but as you know, government by its own nature is bureaucratic. Why is it bureaucratic? Every time there is something which affects policy, they are looking at the implication. If this is utilized, will it offer the benefits that are written in it? Will it be beneficial? Will it be a problem? So usually government takes time because there are many levels of approval. We shall do as Ministry of Health, but when we require probably a certificate from NEMA, they may take another period. Maybe if we require financial implication, Minister of Finance may take its different time. So it is all. Then there might be a statement in the document which you want to be approved, which again goes against the beliefs of the government or the country, and that becomes a to and fro. But I'll submit to the Director General because I'm not very competent to say on approval of policies because Director General's responsibility, PS and the Minister. What we do is to support and ensure the documentation is complete. Even in your submission, make sure documents are complete. I'll tell you that when I came to Ministry of Health, when I told them I needed a policy, within 2 years, they said that one has never happened. The minimum period will be 10 years. But I will tell you, we had the determination and we had to move from one office to the other. Wherever it gets stuck, we are there. And we used the 4 years. I think we started in 2018 and our approval of the EMS policy was 2021. And this is the first one to be approved in less than 4 years in the history. But it is not the problem of the people. It is an office can receive which does not understand whatever you have written, your science, your what, but the person approving did not do your science and is supposed to approve. Without his approval, you can't move. So it's your duty to go and interact with that person. And he may be at a very high position. Like I'll give you an example. During that time, I failed to convince the head of policy, who creates policies, the commissioner who creates policies to go to cabinet. I failed to convince him. But I convinced the one who is higher than him. When I realized I had a bottleneck here, I went to the person higher. How did we do it? Because the person higher was to be contacted by our minister. So I had to go to the minister and request that you need to deal with this person, and he breaks the barriers. And fortunately or unfortunately, those people wrote a wrong reply
to the PS, and the quotations they were making were wrong. I had that night not to sleep because this was a moment which I must use. And I used that moment to say, you know, the quotation you used to throw out our document is wrong. The right thing is this. I go to another one. I say, and you know who is writing that? The minister. When it went, the next meeting we had, people were now listening. And that is how we happened to reach cabinet. But it had stayed there in that office 1.5 years. So it's not easy to have a document, have that level of flow. Then the issue of ambulance costs. Of course, we can notice, you know, those of you who are old enough, I think can remember, was it in 2001? His Excellency, the President, during the campaign, removed these payments in health facilities. He removed, yes, that fee for service. It was removed. And it is only him to say it is back. So we cannot sit and write a document that ambulance services are for a cost. No, we can only write a cabinet information paper saying that we need more money for ambulances because Mr. Kwezera has observed that people are paying for ambulances. But one, as I told you, by giving us 10 billion, it's good. It shows the government understands, and finally we shall reach where we need, where we have a full operational system. Thank you.
Thank you.
We will have so much, my panels, and time is not on our side. I want to thank you so much, and I want to request that you give them a round of applause and as break for tea. And I also probably think that we can have a picture and as with part. And I thank you so much, people, for giving me the opportunity to take the chance of being the first moderator of the day. JB, can you have a picture here?
We are also going to have a general picture after the panel's picture, and then we have one for the moderator and the team, and then the other one for everyone. Yes. So good. All right, I think let's all join in and have the photo for everyone. Let's move a bit fast. Our breakfast is becoming cold. Thank you. Let's go to the next room for our breakfast. We should be back in the next 15 minutes. Your phone. Welcome back from the breakfast. The ladies and gentlemen who are still having breakfast, kindly join us so that we can proceed. Next, we'll have a presentation from the World Health Organization, and then after that, we'll have a panel discussion. So, let's please ask our colleagues who are standing in the corridor to join us so that we can proceed with the program.
I've succeeded. So good morning, colleagues, distinguished guests, and the media in the house. It's my pleasure to moderate this important session on healthcare financing, looking at current priorities following recent health aid cuts. I've already been introduced by Dr. Jebi several times. Maybe just to re-echo that. Again, Maria Nkalubo. I'm the in-country coordinator for the Uganda's Road Safety Program and a Global Health Advocacy Incubator. But apparently, a daughter, more or less a daughter to Dr. JB, because we worked so closely, driving EMS to where it is now. Ladies and gentlemen, in recent years, Uganda, like any other low middle-income countries, has experienced significant reduction in external health financing. This is just a brief background to the session we are going into, particularly for areas historically supported by major global health initiatives. Of course, these cuts have coincided with rising healthcare demands, given the growing population, that an explosive population that we're experiencing, and persistent level system gaps. As a result, our country is now navigating a complex but necessary transition. We are waking up as a country, navigating ways in which we can move away from a donor-funded healthcare system to a self-sustaining and domestically driven health financing model. Ladies and gentlemen, still as I'm trying to provide context to the next discussion, allow me to highlight a few realities that are shaping our national context in terms of healthcare financing. Number one, there is of course decreasing external funding for HIV, TB, and malaria, which further is placing added pressure on the national budget. And of course, we're already seeing some implementing partners. WHO is not among them. We're already seeing some implementing partners reducing program footprints or shifting responsibilities back to government systems. We're also seeing declining primary health care services, much as there's been much effort in improving access to care in terms of the number of health facilities, especially at community level. There's also been advocacy for an increment for the wage bill for health workers. But I can still say funding for essential medicines and service delivery is still very inadequate. Then number three, another context you need to have before we get into the presentations is the discussion on the National Health Insurance Scheme, which remains a long-standing priority with ongoing discussions on how to design an equitable and implementable model. I'm glad at least we have Minister of Health here. They will further allude to that. Of course, with the decline in aid, this has reignited debates within Ministry of Health and other government agencies on how the National Health Insurance Scheme can serve as a long-term pathway. That is, context number three. The other context we need to... No, I'm not presenting. I want you to just listen. The other context that I'm bringing forth to you is out-of-pocket spending, which remains high. As health workers, government officials, you very much know that it accounts for over 40% of the total national health budget. Of course, this leaves households in a vulnerable position, particularly in rural and low-income communities. And many other contexts that you can think about when it comes to health financing and the donor aid cuts. Ladies and gentlemen, of course, those reflections, that context I've provided, brings forth a question, a central question amidst us for today's discussion, and that is, how can Uganda strengthen healthcare financing in a way that is realistic, resilient, and equitable in a post-aid cuts environment? As a moderator, the next presenters will be expected to unpack this through 3 lanes. Number one, the priorities that we need to take on as a country in terms of healthcare financing, because if you talk about protecting the gains, with aid cuts, there are chances of reversing the gains the health gains that we have registered in the recent past. Then number 2 is we are going to hear which domestic financing avenues we must consider as a country. Is it insurance? Is it taxation? Is it efficiency reforms, where you see governments recalling agencies? For example, you've had UNRWA has been recalled back to Ministry of Works and Transport. In health, there are proposals already that are yet to be implemented. Number 3, how do we ensure that reforms are people-centered and not increase financial hardships? On that note, ladies and gentlemen, allow me to usher in the representative from WHO, and that is none other than Christabel. And she's going to be presenting on implications of healthcare funding cuts for Uganda at IP level, gaps and recommendations. Over to you, Christabel.
Okay, I think I'll be able to move the slides with this. Okay, good afternoon, colleagues. I don't know if someone is moving the slides for me. I'm trying to move back, but, or do I need to point somewhere else? Not here. Here? Okay. Good afternoon, everyone. My name is Christabel Abewe. I work for the WHO in Uganda. I lead the stream of work on health financing, and I'm really, really privileged to join you this afternoon. It's been tough, as you know, the JRM is going on, and we're expected to be there, but we prioritized this given how important this topic has come up on most people's radar. And this year alone, I can't tell you how many requests we've received from various programs to come and speak to them about what the aid cuts are potentially going to do for their programs. So it's really a pleasure of mine to join you today. And I've prepared just a few slides to give us an expose on how Uganda's financing is looking in comparison to peer countries in the region. And of course also touch on the implications of what the current realities are dictating for us. So just to begin us off with some context, as we all know, I think everybody by now knows that global health right now is under threat for financing. We've seen rapid and even abrupt disruptions, mostly by the US government when they reformulated how they would like to channel their aid to countries. Now, what we did not automatically see as country folk, what we don't really know is the bigger global health initiatives that we all are plugged into, Global Fund, Gavi, the World Bank's GFF, all of those have a back donor, okay? Because the money doesn't fall from out of the sky. So their back donor is primarily the US government. So the cuts are, for us country people, very obvious for USAID. But what we don't see on the back end is cuts also going into Global Fund, cuts going into Gavi, cuts going into GFF, and then of course the geopolitical situation that happened in Ukraine and all these European countries, they now all started prioritizing security, domestic security. So these bilateral governments also sometimes used to give us aid, and have now shifted their priorities away from global health to domestic security concerns. So we have a myriad of problems happening at a global level. And so this is really, really creating the context that we're now operating in. And of course, it puts us at risk. Why does it put us at risk? 50% of our total health expenditure as a country has been coming in from aid. Okay? So that leaves us very vulnerable to shocks and disruptions. And like Maria was saying, possible reversal of the good gains we've had. I think when the latest UDHS, Uganda Demographic Health Survey came out, 2022, we saw that we've made some really good gains, especially around maternal mortality ratios and neonatal mortality ratios and things like that. We're now really doing well compared to peer countries in that regard. But we potentially risk reversing those gains because the main bucket of financing we've been relying on has been abruptly removed or even reduced in a way that we did not prepare well for. Okay, so I think that's really the big concern. And the WHO has gone ahead to call this the greatest disruption in memory. These are not my words. At a global level, okay? So Uganda is not uniquely suffering this problem. It's cutting across. Now, why is Uganda's problem a little more nuanced and difficult to deal with? I've already mentioned to you that half of our total health expenditure envelope is coming from aid, right? Now, half of that aid is bypassing the government system, okay? I don't know if most of you know in the room terms like on-budget support and off-budget support. On-budget support is people like Gavi and Global Fund who send their money through our government system. It's on the PBS, it's appropriated by Parliament. It eventually comes down to finance and the other people who are buying vaccines and etc. So that's 42% of our aid. Now 52% of our aid is bypassing our public financial management system and being implemented by agencies like WHO, like UNICEF, like the rest of them. That's not good health financing. Good health financing requires that we put money on a government system because we trust it. It's visible, it's aligned to priorities, all the good things that come with it. Of course, there's trust issues about corruption and leakage in the system and all that, and that's where we find ourselves in the place where we're in now, where half of our aid is bypassing the system. But that's a concern because when money is on the system and it starts to reduce, the government picks that up already and starts thinking of how do we balance the boat. But if the money is going off the system, the government has no idea how much is out there. And so we find ourselves in a peculiar situation as Uganda where we have more than half of our aid bypassing the government system. So all these concerns have really warranted coordinated action, really, to protect the progress we've made and of course to safeguard the population. So that's just on the background. And so why is this topic important right now, and what are the possible implications of why the cuts, how will the cuts affect Uganda, for instance? I've put in here short-term effects. We expect in the short term there's going to be abrupt donor exits, which we've already seen. We've just commissioned an assessment to really do a deep dive on how the cuts are affecting even the global health initiatives like I had mentioned, but also to do some modeling to project for us 10 years looking out, what will the landscape be looking like? We don't have the results yet, and we're partnering with Macquarie to do that analysis. And it will be interesting to see how in the short term the donor abrupt exits are affecting the sector. Of course, we have program disruptions. As you know, we had to do integration as an immediate reform, and I understand where the government was coming from. That was, in my view, the best option to take. Now we're working backward to try and perfect that policy reform. So there's been some program disruptions, but we're basically flying the plane as we build it. So there's going to be lots of trade-offs, lots of imperfections, but that's something we are dealing with as an impact. In terms of the medium-term effects, we envisage there's going to be increased pressure on domestic financing. And maybe just to mention that we are operating in a tight fiscal environment. So every year you'll see that our budget, our national budget, is growing, okay? I think in the last year it increased to 7.2 trillion, which had 720 trillion, sorry, which had been moving from above 500. So it was a big jump. Now that big jump is not explained by our economy performing so good that now all of a sudden we've expanded our fiscal space. No, it's coming in from borrowing. So that's a very bad fiscal environment we are operating in generally. And now we are saying that with the budget cuts, we're going to apply more pressure on that constrained fiscal space. So that's for the medium term what we expect, because we see that even though the American government is now renegotiating, they're very strict now with, this is exactly 5 years outlook, nothing beyond that. And they're basically asking the government for counter-financing, which is good for sustainability, but it's putting pressure on our fiscal space. In terms of the long-term effects, we expect that there's going to be increased need now for domestic self-reliance. How do we do this? We need to innovate. I think we cannot do business as usual anymore, so we need to innovatively think through what other alternative options are out there. And Maria spoke about things like insurance, and I have a slide on innovations as well coming up, so I don't want to preempt that. But most importantly, efficiency. I think efficiency is our short or low-hanging fruit at the moment, because what it does for you is it does not necessarily give us new money into the system, but it frees up resources that we could have been using in an inefficient way. So it expands our fiscal space, so we are able to buy more health with the same resource envelope. And that's why efficiency is very much within our wheelhouse to implement and change. The rest of the financing agenda is actually sitting with finance and parliament and other people. But for us in this room, efficiency is something that we can contribute to and actively use as a vehicle to get us some more money. So overall, what's the impact that we anticipate? We think there will be a reversal of gains if we don't solve these problems and mitigate the impact. If we don't have a reversal, that's worst case scenario, we'll have stagnation as best case scenario, which is not a good outcome, because we want to be progressively improving. We also expect that there will be innovation slowdown. I think as Dr. JP was speaking about earlier, some innovations that Uganda has been able to do, these are mostly donor aid funded. So we expect that there will be slowdowns in that case, and ultimately all these things will lead to worse health outcomes. Okay, so that was to set the stage in terms of why this is important and what are the possible implications. But I just wanted to show you some data from the WHO Afro region, which is basically Africa, and it's 47 countries where Uganda also falls. Just to set the stage for you in terms of financing, how are we doing in the region? Okay, so WHO recommends that countries should spend at least $86 per person if you want to provide an essential healthcare package. And on this graph, that's the lower green dotted line. That's the per capita of $86. So you'll see that very few countries are able to, I don't know if I have a pointer here. It doesn't work. Okay, so from around Nigeria, if you can see Nigeria on the graph, somewhere here toward the right, my right, Nigeria is the first country to cross the threshold, and then going all the way this way, these countries are able to finance or to meet the benchmark. Uganda is somewhere with the circle on it. You see that we're still far off the $86 threshold, and that's because our per capita spend is about $57. So we are not spending enough money as recommended or as a benchmark to meet. Now that benchmark that I mentioned, the $86, was recommended in 2012. So the WHO have come back and revised that number and said it can no longer be $86. Of course, inflation, everything has gone up. So our new threshold is now $240, and that's the upper green dotted line. So already we were falling short for 86, you can imagine for 240. So I just wanted to show you this picture that we are inadequately financing health in Uganda. And that's not unique to us. You'll see the other countries on this side as well. And then just in terms of as a percentage of total budget, I think Maria spoke about it. So when we look at the total budget we have as a country, in the last data point, we received 6.2% of the national budget coming to health. Now, for the region, our regional average is 7%. So most countries spend at least about 7% of their budgets, and that's the dotted line. Again, you see that Uganda with the 6 is falling off even the regional average. We're not meeting the regional average. Now, when we combine those two data points and think through the context that we are also heavily donor funded. I put in this slide to show you the distribution of USAID disbursements to Africa 2 years ago. Uganda is the number 4 recipient country on the continent. So that leaves Nigeria, South Africa, Tanzania, Uganda as the most vulnerable to aid cuts. We are in top 4 potentially worst hit countries. So combine this knowledge now that you have on this slide with the last 2 slides. We are inadequately financing, and even that inadequate financing, half of it is coming from these people, and they are going away. So the situation, without sounding like a prophet of doom, is not looking very good. Now, so that was at the Afro region level. Now I just wanted to show you for Uganda's, sorry, the slides are moving a little bit faster than I am. For Uganda's particular context, we have 3 financing sources, 3 key financiers to the sector. One is external resources, that's the orange bar, so those are our primary financiers, as you see on the graph there at the top. Then we have Ugandans paying out of pocket. I think Maria touched on it. We have one of the highest out of pocket payments in the region, and that's the dotted green line. And then we have the government of Uganda, who are at the bottom of the graph. Good health financing dictates that the blue line should be at the top. Unfortunately, we've sort of reversed the pyramid here. And this graph is basically saying the same information, but just to show you a different graphic over the last 15 or so years. The green bar at the bottom is the external financing. So you'll see that they are the tallest parts of the financing each year. And then you have the blue, which is out of pocket. Then you have the government up, I think it's orange. Now, you don't need to be a health economist to see that this trend has pretty much not changed over the last 10, 15 years. And that's not good. So we should be seeing the orange bar at the top getting bigger and bigger, while the green bar down is reducing, you know, over the years. But you will see that we've pretty much not changed this much. And I apologize that this data is a bit old, up to 21. We have new data points, and I actually have another slide that has slightly more updated data. But post-2021, we've started to see some changes, some good improvements, which I'll share with you shortly. So this slide again shows how health's allocation or health's budget compares to our total national budget. So the big red, the taller bars are the national budget. So you see that as a country, our budget has been growing a lot. You'll see that in this 23-24, we moved from 52 trillion to now 72 trillion. While the health budget is the shorter blue bar, it has also been growing. And again, I'll point out to the year 23-24, we received about 4 trillion, just 4 trillion sharp, but now we have moved to 4.4 trillion. And that's a 14.5% increment. So we are seeing incrementally the budget allocations going up. Now, I must caution us about always capturing the 6.2%, saying health is receiving 6.2% of the national budget. And then they can compare it to like any financial year there, maybe 18-19, and say in 18-19 we had 7.2% of the budget. So now it appears like we're reducing. But in fact, when you look at the nominal amounts, we are increasing. So what matters whenever you're interpreting these proportions, please look at the nominal amounts as well. So it would be very inaccurate to say government's allocation has been declining if you look at the percentage proportions. The reason why the percentages are going down is because our denominator is growing. Okay, so proportionally we are taking less, but nominally we're taking more. Yeah. This is an important slide that if you forget anything I said today, please remember this one, because it's showing us the 3 buckets of financing to the sector. On the first side, I have on-budget development assistance for health. So Gavi, Global Fund, World Bank, etc. The money that the government is able to see fully on their system. In the middle, I have the off-budget resources. So WHO, UNICEF, everybody else who is not putting money on the system. And then on the extreme end, I have Government of Uganda's allocation. Now, the 4 data points you see there start from financial year 18-19, that's a green bar, and the last data point is 24-25. Why am I showing you the 3 different buckets? I want to draw your attention to the middle part, which is the off-budget. What you'll see from the graph, without even looking at the numbers, you'll see that that middle of budget is very volatile. It's up and down, and that's what we're trying to tell partners, that this money that the government does not see does not have predictability. It's extremely volatile, and moreover, it's the tallest bars. So it's the bulk of our aid. But then it's going up and down, it's unstable. So that's not good health financing. And that's why the implications for the cuts for Uganda are very concerning, because the bulk of the money is in that bucket, okay? Now on the extreme end, the on budget, you'll see that for the first 3 data points, it was consistently going up, increasing. That's good, that's predictable, that's okay. Okay, I hope that's better. So the on-budget money, you'll see that in the last data point, we see a slight dip. That's because we're starting to see the budget cuts happening everywhere. So that's a 7% drop, just reinforcing that the decline is happening both for on-budget and also off-budget. And again, I think JP was the one making the point earlier that Government of Uganda's allocations have gone up. It's true. Look at the 4 data points. When you subtract the first data point minus the newest data point, it's a 125% increment. So government is putting money in health again, finally, and that's the silver lining to the aid cuts. I think everything always has a bad and good side. This is really the good side. So it's forcing the government to finance the sector that had been left to partners. Okay, so what do we need to do now to improve financing or just make it more sustainable? One, we need to reimagine domestic financing. It's good that it's going up, but when I run a per capita estimate, it's $15 per Ugandan, so it's still grossly insufficient. It's not enough. It's growing, but still very inadequate. So we now need to strengthen our advocacy for budget allocations to health. How do we do that? The best way is to use evidence. So the data I was just showing you, finance need to look at that data, parliamentarians need to look at everybody who is in the cycle of approving or making decisions around the money, need to have the right evidence. We need to start looking at sin taxes or health taxes. I don't know if some of you already know, but in the last financial year, toward the end of the financial year, the government has increased taxes on tobacco, alcohol, and sugar-sweetened beverage. According to the WHO, there's still enough inelastic demand for those sin taxes to be increased all the way to 75%. So last year's increment was 20% on alcohol and 10% sugar-sweetened beverage, and I think 18% tobacco. Now, we are not going to receive an earmark for that increased sin tax. So it's not that they've increased the tax and therefore whatever revenue they gather, they give to health. No, it will just go into the consolidated fund and increase revenue for the government. And for us, that's a win. We're not necessarily asking the government to earmark, no, for two reasons. One, sin taxes are a cost-effective public health intervention because they are deterring consumption of harmful goods. So we have a health win in that sense. But secondly, we know that the government has now collected more revenue. So we can now authoritatively place a demand on the allocation of the budget that comes to health. Because we know that it was from, finance used to argue and say, health, you're just a consumerist sector. You just take and take and take. You're not giving into the economy. But we've been running projections and scenarios and showing them evidence that they can increase sin tax without distorting the economy and bring in more money. So that's one thing that we are, as WHO now, strongly pushing for and working with civil society to realize. We have leveraging of national health insurance reforms. I know there's been the talk of the insurance scheme bill has been lasting in Parliament the last 20 years plus. We need it to be moved and cleared. Personally, I'm very happy it was not, because it was designed quite poorly. So the design of the previous scheme was saying only people in employment like yourselves are going to contribute to that scheme. And yet from the evidence we see that the only countries that have had success with insurance are putting in government resources to capitalize those schemes. And also, countries like Uganda typically don't use insurance as a tool to generate money. So it's not a thing we're necessarily looking at to raise revenue. No. The premiums are so small and they will not drum up the right amount of revenue we need unless we use it as a new platform to advocate for government putting in money to subsidize the informal sector. So that's the way to look at it and differentiate it. And I hope that the new bill, which I think is sitting somewhere in NPA and they've invited us to have a chat with them, is going to have the right design, which is getting money from government to capitalize the scheme. And when such things happen, then we start to leverage insurance as a new source of some additional money. We also now need to look at private sector as a potential place to crowd in new money. And we've seen some good examples around public-private partnerships for supply chains, for commodities, for community systems. So this is a new area that we're also now considering. And then lastly, we now need to also look at the local governments. Again, they have budgets, and just ask them to prioritize health, increase local prioritization of health financing at that level. Because initially they think it's a national level role to finance health. But now we need to bring it back down to the grassroots. So that's on DRM. The second is we need to make every shilling count. So efficiency and basically optimization. And there's 6 strategies we have identified in the evidence of what really works. The first is to just coordinate better. If we coordinate better around one plan, one budget, one M&E, we are able to have so many cost savings and gains. And we have examples from Côte d'Ivoire and other places in Africa that have done this, even Rwanda, that have demonstrated that just coordinating better alone cuts out a lot of duplication, a lot of wastage, a lot of overlap. The second is pooled funding. We need to start thinking of how, if you remember the bucket of the off budget, that's very fragmented, small pools. WHO has a small pool, UNICEF has a small pool. So how do we get all this money into one large pool so that we are able to cross-subsidize for risk and other things? So the pooled funding, we are making some progress on that front through a virtual pool. Because while we understand that maybe partners are not yet at a place of trust to put money on the system, can we have this money on a virtual space where we see what everybody is doing? So that's a middle position as we wait for the trust to grow enough into the system that more partners put money on budget. I don't want to spend too much time on the others, but maybe just to highlight integration. Integration is, I think, right now for Uganda, the primary vehicle for efficiency and optimization. And we hope that truly this will be an area that will see us saving and optimizing how we deliver services. So harnessing innovative financing. This is another area that we now need to start thinking through, which before maybe we were not strongly thinking about. And you might now have had things like blended financing. I don't know if you've heard those terms before. But basically what that means is that we take donor aid and blend it with some either domestic resources or blend it with some private money so that we diversify and also force the government to put money in things that they would initially not. So for instance, if you've heard about the new US negotiations, they're saying we'll bring 1.5 billion, but for that money, we need the government to put in XYZ amount. That's blended financing, because then it builds sustainability into the granting process. And we're going into the new Global Fund 8th cycle. I've heard from global level that they are most likely going to ask for countries to blend the Global Fund money as well. So we are no longer receiving grants like how we used to. You know, money is just coming to your country and you just spend it how. No, the donors are saying we now need to blend, because blending allows sustainability to be built into the granting process. Results-based financing is another alternative that allows you to get the best value out of the money you have. And thankfully for us, we've made some good progress on this front, because we've just mainstreamed our results-based financing, institutionalized it across the government. There's something called development impact bonds. I don't know if you've heard about them. They basically work like how you buy a government bond and then you get a payout. So these impact bonds are used to get money from private investors. So they are sold an idea, like if you bring capital and we use it to do the referral system or ambulances or whatever, and for these health outcomes, we are able to get in this much revenue from donors, for instance. Like WHO now will not just give you money for your ambulance system. You have to meet some outcomes or some targets. So then once WHO puts the money into the program, they use that money to pay off the investors of the bond. So that's how it's structured. It's a bit difficult, but South Africa has had good experience with it, and we are learning the process and seeing how we could translate it to our context as well. We also need to come up with innovative procurement models. I think we're now hearing a lot about local manufacturing and just pooled procurements to gain some efficiency gains. I already spoke about private sector and civil society. We need to look at them now more closely as a possible source of new revenue. And then, of course, the co-financing arrangements, I think they're already working well for like the immunization program, where they basically ask government to match how much money donors are putting. So as I close, just a few parting shots. Okay, so what we see with the aid cuts and the donor transitions, I am sorry to be the bearer of the bad news, but they're here to stay. They are not going away. So we now have a new era we're working in. And we basically need to ensure that we use the best approaches we know how. And the best so far, we think, is efficiency measures. We need to be as efficient as possible. We need to integrate. We need to save as much as we can, because the envelope is most likely not going to grow anymore. Funding from external sources should increasingly, is going to increasingly require co-financing, like I had just been mentioning. So the blended, the co-financing arrangements, we anticipate that this is going to be the future of external aid going forward. Going forward, everything has got to have some value for money measurements embedded in it. So now more than ever, we need to be results-based. We need to have approaches that have been tested and proven to ensure that we are getting the best value out of the money we have. Again, more than ever now, we need strong partner coordination. And the virtual pool which we're building is promising a lot of potential to improve partner coordination, because we cannot have wastage anymore. We cannot have people doing the same thing in the same region, sometimes in the same district. I think that time, it's from like 5 years ago, it can no longer happen. So strong partner coordination is required to improve coordination and to avoid fragmentation. So again, the last point, value for money, efficiency, sustainability. These three things need to be a top priority now going forward. These are the key implications for the funding cuts that we're seeing, not only in Uganda, but also in the region. Okay, I'll stop here and thank you.
Thank you so much, Christabel, for the very explicit presentation on healthcare financing amidst donor aid cuts. Somewhat, yes, there's some tendencies of doom, but also, you know, a slight, we can feel some slight feeling of hope in the kind of presentation, especially on the part of Uganda. Because seeing government being inspired to invest more brings a lot of hope to Ugandans, and also trust in the system that we are, you know, subscribing to in terms of governance. It's a moment for Q&A. Unfortunately, it's only me and you. Our colleague is in the GRM and were unable to join us. But I think you did a good job. I would just ask few questions. She really did a good job, and that hand clap is not enough. I only have 3 questions for you to take note, and then we open it out to the team before us. Number 1 is, me and you are now at global level, and we are handling global health issues. The word vulnerable populations is quite used, you know, predominantly at global level, last mile, and many, many other nomenclatures that refer to those people that are marginalized. So how do implementing partners ensure equity remains central during such budget reductions, especially for the case of WHO-Uganda relations? And then number 2, I don't want to be a prophet of doom as well, but just in case, I'm saying, if these funding cuts persist in the next 3 to 5 years, what could or what must IPs like WHO change to remain impactful? Number 3, the word efficiency has come out predominantly in your discussion. Efficiency reforms, things that we can do better. Every coin counts. In such an era, what efficiency lessons do we learn from COVID-19, Ebola outbreaks, or other resource-tight periods that can be replicated now? I think those are the 3 questions I have. I'll open it to the rest of the team present. If you have any questions, yeah.
Thank you. I want to join you to thank the presenter. I think she did a very good job, and I learned a lot from her. My question is on the out-of-budget support. Why are our partners refusing to disclose the amount they are investing in health, especially reputable partners like WHO and others? Because we've cried and said, please tell us how much you are investing. And even now there is a virtual registration that partners should register and tell us what they're investing in health, but I'm sure we shall not achieve much. Why are they hiding that support? Then the other concern was, you said you are not comfortable with the health insurance scheme as it was. What was presented in our senior and top management was government was not stopping the investments it's making in health. That was going to be its contribution to capitalize the health insurance scheme unless you have different information. It was not going to stop and then say insurance. It was going to continue investing those resources, but then the population would add on starting, and it was not only those in informal employment. But you know, they are the hanging fruits. We are going to start with them, eventually finding ways of getting to those informal people to enter into the scheme. The other thing was on the, I mean, we needed to applaud the government that it is increasing its contribution in terms of nominal figures. And I was in the GRIM now. There is hope that the government will continue increasing the resources, including deployment of more health workers, investing in CHOOS. Maybe there will be another forum where I will discuss those. But it's not all doom. Government is aware that our partners are reducing resources, but we must increase domestic financing, but also increase on efficiency. That's why we've introduced integration, and some countries are actually coming to learn from us. I thank you.
I take also the opportunity to thank the presenter. On the issue of innovative financing, where you demonstrated the component of government versus external sources of funding, I was wondering which parameters you utilized when coming up to government funding, because some presentations indicate government funding being more than external sources, where they look at issues of infrastructure, human resource, co-financing under other different programs like World Bank and many others, government being more than external sources. But I was wondering what cost drivers you used to come up with the government, or it's just the budget that you look at. Then two, the component of what we should do. Could we maybe demonstrate what we can do at short term and what are the long term during your presentation? What are the critical items that we should do during this financial cut? And then what could we do at long term? Maybe if you could look at that also to can support.
No ladies asking questions. Let me start from here.
Thank you very much, Doctor, for the wonderful presentation. For me, I'm particularly interested in private sector engagement. So let me give an example. Let me give two scenarios. I think 2 years ago, we did a private sector analysis for investment in HIV, and Uganda AIDS Commission was interested in what can we do with the private sector. So we realized quite a lot of things. So every year, Airtel sponsors the Uganda AIDS, World AIDS Day, and about 1.6 billion is collected. So my question around what you're doing around blended financing, reporting, programmatic monitoring, and having one plan, how have you engaged private sector? You might find that we have quite a number of civil society organizations which are doing a lot of work, but if you go and check on the MTN Foundation, they spend about 1.4 billion on different activities within the healthcare space, on system strengthening, on awareness around how are you engaging the private sector players to see how they can actually join in to implement some of the activities, blending in with the country programs, because some of them have confusions around what exactly can we do, what is needed, and how is this contributing to the probably 95 goals for HIV or any other activities. Then the second one around civil society is to what extent are you engaging the civil society organizations looking at the different programs that they're implementing, and how is this ensuring that we are able to capture all the key needs? Uganda NCD Alliance is doing a lot of work around preventing and promoting or monitoring or controlling NCDs. But to what extent are they engaged with what government needs to do, and how are we ensuring that at the end of the day, we're achieving the goals of ensuring that maybe we have a society free of NCDs? So I'm more interested in the engagement of the outside stakeholders, most probably society and private sector. Thank you.
Yes, thank you so much, Dr. Christabel, for the nice presentation. I have two questions. One, in your presentation, you well demonstrated the need for, if all the off-budget support goes direct to the mainstream budget. But I would think the position of the WHO in this country could have supported in that, because one of the reasons being given by everyone, including you, is the lack of trust, especially in these African governments. Working system. This is why some people decide the money remain off budget, not to go to the national budget directly. So I would think WHO could have dedicated its time in supporting, in building such kind of trust. And that trust will be not just like preaching in a church, like you need to behave well, need to account well. In all those countries where we say there's a financial transparency, they put either physical barrier or barrier using technologies. For example, if you feel like you want to monitor what is happening in this room, you put a camera. I'll give it an example. But if you think you leave the people, then they, based on their own behavior, the way you have preached to them, they behave well. For most cases, they are not being successful worldwide. So one of the technologies worldwide is blockchain technology, where you make sure every financial inflow is monitored, but not by one entity, by the different entity. Every deliverables is monitored. Tamper-proof, no one can tamper for that. If you can, entities like WHO support Ministry of Health maybe as a pilot to build such system, that will be the way of improving the transparency. So even the money from you, the WHO, you can ably say, let's put it on budget. We are here in the country going to monitor what is happening. So I feel that could be a better way of doing things than saying the lack of trust. It will continue to remain for 100 years, that the lack of trust will remain off budget. Number two, when you look at the funding of the UN as a whole, WHO also being part of the UN, they're equally affected by the financial position America is taking. When you look at the biggest funder for the entire UN, you find the US fund more than maybe half, sustaining the breathing of the UN, including the WHO. So how also are you responding to this shock? I feel maybe WHO also and other UN agencies are also affected equally. In the alternative way, you're trying to look around to support the WHO entity. Otherwise, if you don't, I feel the WHO will remain also onlookers in the country where they're staying. Where, for example, you have office in Kampala, you'll be remaining also onlookers, doing nothing because you not have the resources to support the budget. Yes, thank you.
Thank you. Allow me to say your word in Rufombira accent, Abewe, right? Thank you. So amidst the donor fund cut, government of Uganda has come up with some interventions like integration of health services, plus other innovations. Why are we worried of long-term effects, yet we have these other innovations in place? Then, in your own view as a health economist, do you think that our budget is being utilized properly, appropriately? Last time we saw URA staff rewarding themselves with 29 billion. Don't you think that would have gone to healthcare system? As you said, every shilling should count. Lastly, national insurance scheme has been a talk for the last many years. Do you see it coming? Thank you.
I'm having a, yes,
Thank you so much, Christabel, for the wonderful presentation. WHO as a development partner, because when you look at what you presented, somehow I kind of got lost. I don't know whether you are advising government or probably whether you are trying to point to us what is maybe the doom, like you said, somehow you are like, oh, some information was like making recommendations, then actions. But my issue is, in this country, as development partners, do you have a time when you engage government and maybe speak to them? Some things could be discomforting, but I think we look at them as the whole source of the problems. I look at the number of districts that we have in this country. And the other time I was asking myself, I come from a district, I've seen it being divided from, I just want to give an example. That was Hoima district, then it eventually became Chivade, now I'm in Kga. So you can imagine how many districts were covered. There are now over 10 in one region. And now by that time, there were 2 hospitals, and there are still 2. That was Hoima Hospital and Kagadi Hospital. And they are still inadequately equipped or staffed or facilitated. So the monies that are used to run those districts, if they remained 2 districts as of now, or 3, and then these other monies are put into those hospitals, we wouldn't be having good hospitals. So what am I saying? Development partners, why don't you advise government on the appetite of creating many districts? Another example is Ugandan NCD Alliance. We support some districts as branches. We do some work in branches. One of the branches, I'll take an example, is Arua. When we started supporting Arua, it was 1 district. By now, it has about 5 districts. And when they chopped it into 5 districts, administrative units, the health facilities were supporting. Coincidentally, each district went with 1 facility. So now I have to go to 5 districts when I'm going for a supervision or a monitoring visit. And then I have to go to 5 DHO's offices. And sometimes it becomes very, and I look at it and I'm like, really? All this waste. So the waste somehow we have here is what causes maybe the challenge that we're having. And even if the donor cuts are reversed, we'll definitely have our own problems within our country. So why don't we advise government to start looking inside before we think of bringing resources from elsewhere? We start by consolidating what we have. Thank you.
Wow. That's how important health financing is. And over to you, Christabel, but I also request Minister of Health officials to come in, especially when it comes to the last questions regarding districts, regarding, consolidation of the different interventions as asked by the NCD Alliance. I know Christabel can, but just answer a few of those. Yeah.
Yes, thank you, Maria, and I'm glad that I have Dr. Gerald in the room, because some of the questions are for the government. And maybe I'll start off with the last, going backward. Dr. Kwizera, your point on do we engage the government? So we have governance structures where the government and partners in the HIPAC, if you know the HIPAC, we co-chair the HIPAC. So that's a monthly touch point. At least every month we engage with them. And we also sort of co-create the agenda and have discussion points that we think are beneficial to both ends. So that is happening. Outside of the official governance structures, we also try and have a monthly meeting with the PS, or at least quarterly, if not monthly. So our chair, our co-chair, when I say chair, I mean the chair of the Health Development Partners Group, because we have one group. So the chair every year, the co-chair, and WHO is a permanent co-chair, and the secretariat. So the 3 of us try and meet the PS at least every quarter or monthly if possible to discuss on priority issues. Now you must appreciate that our position is that of technical assistance and guidance, but we cannot force the government to do what they feel is right. So the best we can do is share global best practice, share even with the rationalization of districts. I mean, the government is trying to now do the RAPEX and rationalize, and hopefully they will come down to the districts as well. I don't know. I feel like that's a very political agenda that's sort of even outside of health itself. I understand that it's a source of gross inefficiency, for sure. But is it at all in our wheelhouse to influence? I'm unsure how much power we have on that front. But by design, we find ourselves in this situation. So how do we improve it? When you speak about going to 5 districts, at least my assumption is that you took one trip. So you didn't go and come back to the center and go and come back to the center. So we can design our support supervision, we can design our interventions in an efficiency gaining even with supervision. If that all within the same car, travel once, use the same driver, same fuel, same visit 5 to 6. So we just need to think, what can we actually achieve, or what's in our remit as health that we can actually influence? I think that's the reality of the situation, but I'll definitely defer to Dr. Gerald to pick up on that question as well. To the speaker before on integration, why are we worried yet we are integrating, for instance? Now, if you recall from my first slides, I showed you how inadequately we're financing the sector, right? So while we are integrating, that's not going to bring in new money, as I mentioned. So it will leave us with the exact same money that we currently have, but we are now just using it more efficiently. But that does not take away the inadequacy. The inadequacy is still there. And while the inadequacy is still there, we have challenges with half of the money that we currently have going away. So we cannot run away from trying to get in new money. Efficiency is one way to look at things, but it's not enough. So we are going to have to combine various ways to try and get in more money. I want to take your point on national health insurance and also respond to, I think Dr. Gerald has also touched it a bit. Okay, insurance is a big elephant in the room, and we need to unpack it a little slowly. So if you can just give me 2 minutes to just focus on the insurance question. Okay, so by design, Dr. Gerald, the insurance scheme was not going to take away government's allocation to the sector. No, we're still going to get the 4.5 trillion or however much we're getting. That's fine, we still expect that. Now, the insurance scheme by design is supposed to give you access to healthcare services at any level with whatever condition, as long as you have a card. I don't know if you have private insurance, you know how it works. So imagine every Ugandan having that kind of thing, and they're able to come to Nakasero Hospital, they're able to use whichever facilities we've accredited as a government, and they're able to get those services. At the end of the day or the month, those facilities are going to put in their claim to the government to pay. Now, remember that the 4.6 billion that we currently have from the budget is for salaries and things for maintaining the sector, and it's still inadequate. So we are now not talking about this additional, the insurance was supposed to be a completely different thing. And how we've designed insurance schemes is we capitalize them through premium collections. So people who are members of the scheme contribute. Now, in an informal setting like Uganda, where we have 80% of the population in informal and 20% in the formal, it means that we can tag our premium collections to the 20%. The informal sector doesn't mean that they don't have money, because we have people in Chikubo and wherever, they have a lot of money. But the evidence shows that it's very difficult for you to collect premiums from those people. If you remember the tax things from back in the day when they used to get people and imprison them in the villages, you remember those? Those were very difficult to collect. And I think that was under the mandate of URA or finance at the time. Now we would have to turn our sector, our health sector, into a tax collection agency if we went into informal collections from the informal sector. Basically people who you cannot take their premiums from source, like us who have a paycheck. So Kenya is grappling with that reform right now. They've just redesigned the insurance scheme and they've said it's mandatory. Every Kenyan must pay, whether you're in informal or formal. And they're not collecting the money from informal. And I was bored. I went to Kenya for 4 months when they were redesigning their scheme. And I said to them, by design, mandatory insurance is the way to go. But you're not going to collect this revenue. It's very hard to collect. I think URA right now has 4 in Uganda. It has 5 million or so taxpayers, eligible taxpayers. But they collect tax from only 1,000. That just shows you how difficult it is to collect revenue from people or premiums who are highly informal. People are not willing to pay this money. As long as you don't have access to their paycheck, and you remove it from source, they will not pay you that money. So it's very, very tough. And so what the governments, and this is only Ghana and Rwanda that have successful insurance schemes, what they are doing, Ghana has given up its VAT collection. 100% of their VAT collection goes to health insurance. So they would receive their budget allocation, the 4.5, then they would also collect all their VAT and use it for insurance. So that's what I meant by government capitalizing the scheme, as opposed to relying on salaried labor to be the ones to finance the scheme. It's very unfair and it's very aggressive, because then they'll take your contribution and use it to cover 15, 20 other people in the informal sector. So by design, that's what I meant, that we needed to also have money coming in from government to capitalize the scheme. And the government didn't have an appetite at all to put in money into the scheme, because they want to continue with the budget allocation, but they're not keen to now also capitalize an insurance scheme. Let Ugandans contribute that money. But that's going to be very tough. And so that's why by design, I was saying we need to design it in a way that's going to be sustainable. While Ghana is putting in all their VAT, by the way, if you should know how expensive insurance is. Their monthly claims, monthly, are $20 million. That's how much bill in total the insurance scheme gets, and they have to pay facilities that are provided. $20 million. Insurance is a whole industry out there. And again, to say that Kenya, for instance, has had insurance for the last 65 years, their coverage is under 25% with all the efforts. So I'm just, as a health economist, I wonder if insurance is actually the magic bullet. Is this something that's actually going to solve our problems? Because number one, it's well established. It's not going to raise money. It's not. Even with Rwanda and Ghana, where it's working, I've told you it's government schemes. It's government putting in money into those schemes. It's not that they're collecting money from Rwandans. The premium collection is less than 10% of the total scheme. So in fact, when we look at insurance as a innovation for Uganda, we don't look at it primarily as a source of new money. We look at it as a vehicle that's going to help us pool resources better and strategically purchase. Because financing has three functions: revenue raising, pooling, and purchasing. So we look at it as something that will solve for us the other two functions, but not necessarily bringing in new money. So let that always be at the back of our mind. And I've had a lot of trouble discussing insurance with people because they're almost just emotional about it. They're not willing to be logical and rational. They just want insurance. We're the only ones in the region without insurance. Okay, but our UHC service coverage index in Uganda right now is 49. The global regional coverage is 47. So number one, we're above the regional average. Number two, Kenya, which has 3 times our budget expenditure, has a UHC service coverage index of 52. So we are performing almost equally, except they're putting in a lot of money that's not doing what it should do, because these schemes are very complicated. And the last point on insurance, the national budget, your national budget, is a form of insurance. Because the technical definition of insurance is prepayments. So me, Maria, this one, all of us, we prepay. We put the money in one pool, then we use it to purchase. We do that with our budget through our taxes. So all of us are already prepaying. My team lead from HQ is called Matthew. Matt always says, your insurance, your budget, your national budget is your best form of insurance. Place the demand there. Ask for a bigger share of the budget. So for me, if you asked me, we keep advocating for the budget to get a bigger cut of it, and we avoid the insurance situation. Because Ghana has 50% coverage, and their insurance scheme is 20 years old. So you can see that for you to just get 50% coverage, at a minimum, you need 20 years. I have a very interesting presentation on insurance. I'll share it with Maria, and she can circulate, just for you to see how other countries are performing. I hope I've sufficiently answered your question of, is it coming? I hope when it comes with those right design aspects. Somebody asked, what are we doing about trust? This is an important question. Fortunate for us, last week we were in Geneva for a global meeting on PM, on public financial management systems, and how can we strengthen the systems and basically put money on the system. And somebody made a good statement. I'll never forget this. She's a lady from UNICEF. She said the only way you can test the system is by you putting money on the system. Otherwise, as partners, we can speak all we want about, we don't trust the system, but the only way to know actually if your mistrust is not unfounded is if you put money on the system and see how well it does. And so I'm starting to think we can design incremental ways, like we take a discrete amount and say, for WHO's budget, which is 100 million, for instance, let's discretely put 5 million on the system. Let's see how that 5 million performs. And then incrementally, so these are the conversations that we had last week, and we're hoping to translate them in country. But we're also not doing absolutely nothing and just folding hands and saying we don't trust the system. No, the World Bank, for instance, is really, really supporting the public financial management system, as well as FCDO. So we are progressively supporting the system, and IFMIS has really improved. It's now gone, I think, cashless completely. So all these reforms to the IFMIS alone are enabling the trust to go up. And I think it's a big, big win if the US government's renegotiation puts most of their money on budget. That would be a big win. And sometimes when the one major financier goes one way, then you find the rest also just following. So we're hopeful that at least with the Americans, we'll see more people putting money on there. Somebody asked about private sector there. How are we engaging with private sector? I know that if you ask me, one of the major missed opportunities in our sector for financing is private sector. And I think that goes to your question also. During the previous Ebola and COVID, what things did we learn for efficiency? I think we saw that there's a lot of power in private sector, especially during COVID. Not just power, but goodwill. Sometimes the goodwill is even more important than the people's money. Because if you have their goodwill and they're seeing that there's going to be good outcome, because you know private sector is all about input, output. So if you demonstrate that consistently, then I think there's potential that it's suddenly a big missed opportunity. And I think we need to build, at least for WHO, we need to build a stream of work around private sector engagement in the next year, because it's becoming more and more clear that it's a missed opportunity that we need to now look into. After all, we're out of options. It's not like we have too many options on the menu. I think now we really have just domestic financing and private sector. Somebody asked a question of what parameters did we consider for government of Uganda's financing versus, I think, donor support. I don't know which data you looked at, but it's been very, very well established that for the longest time, and the data I was showing you is from the national health accounts, which date back to the early 2000s, development partners have been the major financier. That's just guaranteed. And when I say for government, we are looking at their recurrent budgets, we're looking at wage, so it's wage, non-wage development budgets. So it's everything. And even then, the partners still provide more, followed by the Ugandan paying out of pocket. I really, really wholeheartedly thank you for your comment on structuring the recommendations for short-term, medium-term, long-term. And like I mentioned, we've commissioned a full analysis on this, the impact of the budget cuts. So the structure of the report will definitely have explicit recommendations sequenced by short to medium framework timelines. Not lastly, I still have some comments from you, but Dr. Gerald, your question on how much is off budget. So we've been struggling, it's true, to get the off budget data. And I have been the focal point for that analysis, together with UNICEF. And we've so far compiled 5 cycles of the off budget resource tracking. The report is now available. We've shared it with Ministry of Health. And for the first time in so many years, because we started this in 2018-19, when finance kept telling us, we cannot give you more money because you people's money is off budget and we don't know how much it is. So to disarm that narrative, we started tracking this money and we compile it in a report. And another key outcome out of that narrative was that the Ministry of Health now started a department, the partnerships one, the one that Aliti used to lead, and now it's Brian and Joshua. So that department, which also, back to your question on private sector engagement, that department is supposed to be engaging with all external partners, private sector, development partners, etc., for the sector. And so we've continually tracked these resources. We now have 5 cycles tracked. And in the first cycle, our reporting rate was like maybe in the 70%. This financial year, 24-25, our reporting rate was 95%. So we are progressively seeing transparency increasing. I suppose the other advantage this time was we used a digital tool, which the PS herself came to our HDP retreat and said, this year everybody must tell us. And that speaks to the point of strong governance. We need the Ministry of Health to be the ones in the driving seat of this agenda. You know, you can be in the driving seat, but you have a co-pilot who's showing you which way to go. This time we need the driver to know which way to go. And it's been very helpful that the PS is now very tough. Since the US cuts came on board, there's game stopped. Everybody has to be as transparent as they can. And we're now, the off-budget exercise report is seen as the place where you show us what you're doing. So it's no longer a thing of you can hide anymore. If you hide, we don't know. So it's the narrative switched a bit with partners now looking at the process as this is a place for us to demonstrate and show, popularize what we are doing. I think we've done a bad job at popularizing that output and that report, especially within the Ministry of Health circles. So I think most people don't even know that the report is there. But it is actually published on the Ministry of Health website. So if you just check off-budget resource tracking, you'll be able to find it. It's publicly available on the public domain. Lastly, to Maria's question, there's somebody who asked a question about what will WHO do if the funding cuts persist, and we're doing a lot internally to be more sustainable. So I can only speak for WHO, I cannot speak for other partners, of course. But if you might not know, WHO is a member state agency. So that means our member states pay us a subscription. And that's why WHO works slightly different from other agencies in the sense that the government is very much our boss. So we cannot even do anything without government. And we're very much aligned. We're basically here to work for the government. The UN generally is a international civil service. So we are a member state agency, and we've now increased our member state contributions, because that's the most sustainable way for us to finance the agency, instead of relying on donors to give us money. So that's the one way we've gone about it. The other way is efficiency also. So we've cut out so much of the fluff in terms of just overheads and multiple vehicles and things like that. The meeting we were in Geneva last week, lunchtime would come and they would announce the lunch is self-paid. This was a global meeting with over 400 people. And people were just, at lunchtime, you'd have to go and find your lunch. Like, WHO is not giving you anything. And so we can no longer afford meetings out of town, as you know. So we're really revising how we engage in a more efficient way, and that's been helpful. We've also cut down our workforce. I think some of you have heard that, which is very, very, very sad. And we hope that we get in some more money and bring people back on board. Otherwise, we lose our mandate if we don't have the teams. You asked a question on equity considerations. That's very important. And I feel like this is not an area where development partners perform poorly, because we try as hard as possible to uphold equity considerations. I think for this one, we are not doing too badly, and for us in the UN, we have to mainstream gender, we have to mainstream equity, there's no money you can spend from the UN without demonstrating how equity considerations have been upheld. So I think for us, we are not doing too badly, but on the government side, we still need to do more, especially with the resource allocation formula, just to ensure that the districts that deserve more, maybe because they have higher disease burden and all these things,
are receiving what they need. I think let me pause here, Maria. I can continue bilaterally. Yeah, thanks.
Yeah, a big hand clap to Christabel. We are so much privileged to have you, and I think the organizers did a good job to identify Christabel as the rightful speaker for this session. Is that right? It's right. So she deserves another hand clap, surely. And I'm not so sure if Dr. Mtunji and the team from Ministry of Health, the question on National Health Insurance Scheme has been answered, because it was serious. Yes. Of course, I also wanted you to just point out on some of the efficiency reforms that Ministry of Health is having in place. The time I left last year, they had already started introducing those efficiency reforms. For example, integrated support supervision. You see PS carrying all commissioners from all departments to Uganda attend to one single support supervision. So what are those other efficiency gains? So we can further build trust. Christabel is here. She's talking about trust. Last weekend I was in church and the pastor said, you can't say you are faithful when it comes to money up until, and you're very poor. You're very poor, you've never earned 50,000 a month or 100,000 a month. Okay, the people I'm having here, you've never earned 50 million a month. You see? And then you say, I can be entrusted with 100 million. You're convincing Christabel, give me that 100 million. I can confidently utilize it. I'm very faithful. I cannot take a coin. But this is money that you have never dreamt of even earning. So the pastor, if I refer to Christabel's message, was saying, up until you get that money, the $5 million she's talking about on the account, and you prove that you're really faithful, that's when WHO will invest in more and more money. I'm just reinforcing that message of accountability and transparency on the part of government. So over to you, Dr. Mtunji, in terms of efficiency, and then Dr. Mtunji will be closing this discussion with his points, and so we can have our photo as a team. Thank you so much.
Thank you. You've mentioned some of the efficiency reforms that the Ministry of Health is undertaking, and they hinge on the integration. We are doing a lot of wastages, doing similar things but differently costing money. So in terms of, for example, support supervision, we would go and support health facilities, but each department would go alone and use different resources, and then those resources can be used efficiently if we go as a team. That is one. But also integrating the management of conditions. Instead of having hypertension clinic, diabetes clinic, HIV clinic, TB clinic, it was somehow wasteful expenditure. We are trying to integrate that. But I think the major saving will be on emphasizing prevention and health promotion rather than waiting for diseases. So I think we shall make a lot of savings if we emphasize health promotion, disease prevention, and early detection of diseases. Because if you detect diabetes early and you start managing it, it will be much cheaper if somebody comes with impotence. Because impotence will be very difficult to treat, but also it will affect the family, affect the individual, it may cause suicide, it may, all that cascade. So that is our emphasis. Health promotion, disease prevention, early detection, integration, so that we avoid some of those inefficiencies, expenditures. Just a comment on the Chris's question about having many districts. I think we should concentrate on things that we can do something about, because some of these decisions, we are not part of these decisions. They are political. His Excellency goes somewhere, somebody eats a rat, he says, if you don't give us a district, yeah, I'm going to eat another rat. And then His Excellency says, okay, have a district. We may not have control over that. So let's do things that we have control over, other than things that we don't. But we have raised our voices, and I think now there is a ban on administrative units. Otherwise, even the districts were making more town councils, every village was becoming a town council, and town council has a budget and all that. So there is a ban on administrative units, expanding administrative units. There is a ban already. But when His Excellency went to Tororo, I think he created more districts, and I think there are other districts created elsewhere, and sometimes we don't need to go into that direction. I thank you.
Can we have a photo for the moderator and the... yes. Do you have someone with a camera or a phone? Cameraman. Dr. Muna, come and take for us a photo with your phone here. They are capturing video mostly. Yeah. All right, I think we should stand and stretch a bit before we go into the next session, because it's also about the same financing we've been talking about. I hope the moderator will be able to bring out new insights about that. And it's going to be moderated by Dr. Alfred Jatho. Dr. Alfred, you're welcome to the podium.
All right, thank you so much, Dr. Kakungulu, and thank you so much, the previous presenter. We are extending the discussion so that we go for lunch when we are contented with the financial landscape in our country. But before we go for that, I would like to have these officers in front and then explain the context of what you are going to have. May I have the Commissioner NCD, Assistant Commissioner, Dr. Gerald Mutunji, in front here. And then the Commissioner Communicable Disease, Dr. Emmanuel. Yes, you're most welcome here. And also let me have the Country Program Manager, Uganda NCD Alliance, Chris Kwizera, take a seat. I have only 4 shares, without me having one. I'm going to leave one from there. Also would like to have Christabel to come back here, to present the WHO in this discussion. Yeah. Don't worry, I'm just going to make a summary of that. Yeah, thank you. Allow me to lift one chair here. I'm also aging now, so that when I feel like sitting, I can sit. Maybe in absence of our commissioner, because we have time constraint, we can move forward. So let me again re-echo the context. I'm going to rely heavily from the recent annual health sector performance report, 2024-2025. The health sector report noted that over time, the government funding has been increasing, though it remained below the 15% Abuja Declaration of 2001. And in the most recent years, it went up to 68% of government Uganda funding. Commissioner, I'm trying to give the context that our health sector strategic plan, the most recent one, 2024-2025, states that our funding has improved over time, the government of Uganda, GOU, up to the tune of 68%. 10 years ago, we are below 40%. It was mainly donor funded. But the same health sector report is saying donor funding is also what? Going down over time. But the most recent decrease was horrible. In March 2025, when Trump announced some shift that affected, because the USA give the biggest funding, as you saw from Christabel. Yeah, we are number 4, I think the ODA, but in that ODA assistance, the US take the biggest lead in terms of funding. And then the health sector report also reiterated what has just been presented here. The off-budget still remain a big issue, where the mainstream government not able to account for resource inflow into the health sector. Yet all this funding goes to the health sector. So you may think, when you do your analysis, you may think that we are now okay in terms of GOU funding, that 68% of the service delivered in the country is currently funded by the government. But if you're not careful, you may find when you go to those health facilities in the region where those of funding target, you may find that most of the deliverables are happening because maybe of those of what? Budget support. Which if you are to pull them together, the off budget and on budget may end up maybe exceeding the what? The government allocation. Then given that now, even the on budget support has declined, but the same sources funding the off budget is the same cut. They also what? Heavily affect many people have lost also job. Meaning the health sector could be struggling. That 68% increment may not make us deliver what we are achieving in the last 2 or 3 years. Then when you go ahead and look at the recent reform by the Minister of Health and the government of Uganda in general to react to what has happened, you are seeing that they're saying now, let's do a lot of domestic financing to meet that demand, okay? Let's realign our health sector intervention to agree with the National Development Plan 4. This is what is being called up. Even in the health sector annual report, this is what they are stating. 3, they're saying if the off-budget entities still feel like they lack of trust, put the money into on budget, okay? At least let's know what they are doing and how much in terms of digital display of the off-budget support. So that you're able to know exactly volume of money going to the health sector and doing what you're able to quantify well. So, with so many other reforms. So given that context, I would like each of us here, 4 of you, you're presenting your entity, and try to reflect and then provide insight, understanding to this gathering in 4 major areas. We are going to go one by one. I will start with Dr. Gerald Motunji. First of all, how has the decrease in external assistance affected the implementation of the strategic plan of the Ministry of Health in the context, in the component of the non-communicable disease control in this country? You have the mic there.
Thank you very much for inviting me here. NCDs was not heavily relying on donor support. Fortunately, it was minimal. But I would be lying to say that we've not been affected. But really, yes, there was some reliance on donor support. And when it decreased, it means we were also a bit affected. For example, we had started integrating NCDs in PEPFAR-supported activities. So like in HIV clinics, we are doing screening for hypertension, screening for cervical cancer, screening for diabetes. So that could have been affected. But sometimes there is what we call blessing in disguise. So we are now all crying. We used to cry alone. We used to cry alone when other entities were not crying. My colleague here was not crying. Now we are crying and we are finding solutions together. So they don't have now and we don't have, and now that's the integration is supporting the NCG space. So, and I had already talked about how we are trying to cope. And for us, we think integration is key, but also emphasizing prevention, early detection. And because of the integration now, we think the NCDs will benefit better. Because cases are likely to be detected early. And we have seen an increase in detection, for example, of hypertension, not so much on diabetes. We are trying to struggle with health promotion and disease prevention. So yes, it has a little bit affected us, but not so much because we are not heavily depending on donor support.
Let's share this, yeah. Thank you so much, Commissioner, Dr. Gerald. The same question goes to your counterpart dealing with the communicable disease, that is Dr. Emmanuel, okay? How has this decrease affected the implementation of your strategic plan in the context of communicable disease prevention and control?
Thank you, moderator. Yes, once again, I'm Dr. Emmanuel Toyonjere. I'm here on behalf of our commissioner, Dr. Stavia, from Communicable Disease Prevention and Control Department. I think our department is the biggest department in the ministry, if I'm not mistaken. It has a number of divisions, including NTLP, National TB and Leprosy Program. We have AIDS Control Program, National Malaria Elimination Division. We have UNEP, plus also NTDs. Yeah, unlike NCD department, where my colleague comes from, we heavily relied on foreign assistance. Patricia, you said. So if there's a department which was affected by funding gaps, it was our department. Whereas we are crying together, I think we are crying more compared to him. We saw a lot of changes which were very drastic. We expected some changes at one point, but the changes were too abrupt. We didn't get time to prepare to transition. Patricia, we saw a change in human resource. As a ministry, our work is to do policy formulation, but implementation of our policies and our strategic plans take place in the districts. Most of our IEPs who are helping us implement our strategic plans were told to stop. Or they were, at minimum, they were told to pause. And they were there, swimming in murky waters, not knowing what to do next. So in terms of human resource, we were heavily affected. And as such, we saw our indicators coming down. Quite a number of indicators coming down, particularly for TB, which relied so much on implementing partners. We saw our data also getting worse because most of the facilities were relying on implementing partners to deploy or employ data clerks. So our data came down, it was worse. No one was helping us in doing data quality assessments. We saw capacity building, which is a core mandate of the ministry, also getting affected. Trainings were stopped. And as such, we had to devise ways of doing trainings. Now we had to go virtual, including trying to introduce what we call e-learning. Monitoring activities. In management, we say you want to see what you supervise, but not what you expect. So if you don't supervise your people at different levels, you never know what is happening. But our supervisions were affected. As he has rightly said, we had to go an integrated way. We had to do integration in terms of supervision, but also the frequency of integration. The frequency of supervisions went down. Whereas we were supposed to do quarterly supervisions, now we had to go some areas we had to do biannual. You had to wait from the other disease programs, combine activities. So it affected us in that way. But we also had to pause our activities, a number of activities. Global Fund had to write to us to reprioritize. Some activities were completely stopped. some were paused, and a few were allowed. For example, we had an issue of prevalence survey, for example. As a program, TB program, we are using data of 2014. We've not had any prevalence survey for the last 10 years. And Global Fund comes forward and says, prevalence surveys are not priorities. Please stop. You cannot do any prevalence survey. You see? And I want to use this opportunity to reach out to our coffee brothers, okay? If you can help us do a prevalence survey for TB, so that we know our exact prevalence, it will be very, very useful. Because now we are using data for the of 2014. So the targets we are having may not be relying on true picture on the ground. But lastly, procurements are also affected. For example, Global Fund came forward and said no more procurements of IT equipment, and yet we cannot do anything without IT. So if there is any division which was affected, it was our department, Communicable Disease and Prevention Department. Thank you.
Thank you so much, Commissioner. For the last 10 years, we are not understanding the status of some of these diseases and their related risk factors. Do you think could be addressing the same things? Because now the source of the funding for doing some of these surveys to inform us of some of the important status and maybe direct resources, direct intervention to a particular area where they see where there's more problem. Don't you think we are going blind in that context?
We are not going blind because we use data for evidence. We're not going blind. As a division, as a department, we continuously do our surveillance. We also have our data, but we would want to have a national picture. Okay, because surveillances just go beyond, prevalences go beyond routine surveillances. But we're also finding innovative ways. We are saying instead of having a national prevalence survey, can we also go regional using our limited resources? For example, if coffee comes to us, can they help us support regional prevalence survey? For example, if you go to Karamoja, can we get to know the prevalence of TB or malaria in Karamoja region? Yeah, thank you.
Okay, thank you so much. Let me go to Chris. I'm taking you like you are representing the civil society in this country. Our civil societies in Uganda, many of their fundings, I think much or 100% for many of them, come from external funding. Are you also equally affected by this, what is happening globally? Or you're a bit well protected against this? Yeah.
Thank you so much. As you some representing civil society, we are so much affected, and a number of civil society organizations have actually closed because of the cut down of the recent executive orders, and I think that's what we are referring to majorly. And as Ugandan CD Alliance, we are also purely donor funded from the time, including establishing the organization. Lucky enough, we are not getting funding from the US. So our funding was from Europe, and we are not so much affected in terms of what we get. But in the way, we have been also affected somehow. One, when the executive orders came, it was like just cut at once, and people lost jobs. And then, of course, the healthcare system also was affected in terms of human resource. As a team, we used to ride on the healthcare workers who are in facilities. Somehow they would be able to see the patients living within cities, even when probably they were not their priority. But at least, you know, nobody would discriminate them. And of course, because of the reduction in the resources and the human resource, we were affected. Then the other issue was on the patients. Dr. Jared said that the detection on NCDs has gone a little bit high. Actually, it also increased in terms of the people. People who lost jobs, some of them all of a sudden developed the high blood pressure and NCDs. Then others who are working with these organizations, of course, they are well paid and they had good health insurance. They are getting health services from good healthcare, services in the country. And when that funding was cut and they were sent back home and they couldn't access the healthcare services, and of course now the diseases also grew and became bad on their side. They couldn't access the health services that they were getting. And that's how we are affected. So we have very many patients now, probably who are not having adequate care like they used to have. And that's how we have been affected as Ugandan NCD Alliance and as also that organization. Thank you.
Thank you so much, Chris. Now back to you, Christabel. In many of the countries where WHO operate, the number of intervention where the Ministry of Health could seek from the WHO to support them. The one I'm very familiar with, they'll be doing a number of like polio survey, using a number of interventions, monitoring programs, and so on. And maybe responding to some of the emergencies where the Ministry of Health probably didn't have enough money and could tackle. Has this funding also maybe affected the WHO? And maybe if so, which intervention were worse affected? Or when you did your kind of efficiency rearrangement to absorb the shock and maybe move forward with some critical intervention? What are some of those interventions which are maybe a bit well protected with the little money that you are able to receive from your sources of funding? And which one are really, you think, are no-go zone now? So that we can rethink in case we want to approach WHO for such kind of support.
Okay, thank you. So I think out of the development partners, WHO was worst affected because for us, we didn't just have a cut, we had a full withdrawal of one of our biggest member states. So WHO suffered, I think, the worst. And in magnitude, it was somewhere between 25% to 35% of our global budgets. So that cut translated across from the HQ to the regional offices to the country offices. In terms of directly what areas have been affected, I wouldn't say that, for instance, we would no longer do polio work or we'll no longer do system strengthening. I think we've just shuffled around things and restructured how we were doing them. So for instance, we will not do anything that requires, paying per diems and going up country and doing that sort of thing. We've now streamlined our work to mostly be technical assistance and advisory and less of actual implementation of things that require money out there in the facility. So we are not completely unplugging out of the areas that we were supporting, and we've just developed our new like the equivalent of a strategic plan. So it's going to go running for another 5 years. It's not finalized yet, but in that strategy, we are pretty much covering all the scope that we've always traditionally covered, but we are just reducing the implementation arm of things. So we'll be less on ground. And right now, in Uganda, we had nine regional hubs. Going forward, I think this is the area that's going to be most affected in terms of maintaining a footprint at the subnational level, because these regional hubs would allow us cover multiple districts within one region. So I think if we don't find the money, this is going to be the first place that gets substantially affected. So the footprint at the subnational level. Yeah.
Thank you so much. So let's move to the second round of our question. Also starting with the Commissioner General, but they're all going to answer the same question in a different context. We have seen in the health sector annual report, the funding by GOU is increasing. Even the WHO presentation is showing that in the last 3 years, the funding almost doubled. In terms of percentage, it looks like decreasing. But in terms of nominal value, there's a real cash, real money being put into the healthcare system. Do you think this increment can plug the gap created by the donor funding, either total withdrawal or a significant reduction in the amount contributed to the government of Uganda in the area of non-communicable disease control? And then you follow in the area of communicable disease control.
Yes, as I said earlier, we need to applaud the government for increasing the resources invested in health. And they are promising to increase, because even the human resource issues that my colleague talked about, if you read in the papers, we got some supplementary budget. So we will be maybe recruiting some of those people to be on the ground and offer services. But I would be lying to say that it will cover all the cut resources that we are getting from the partners. And that's why we are renegotiating with some of the partners, including the US government. We are renegotiating. I think they have some conditions. You know, these grants, these resources they were giving us, it's not that they love us so much. They also have their own interests. So they are not ready to, you know, to lose all the interest that they were getting from the resources. So they are coming, but with some maybe more conditions and what. So yes, the government has accepted to increase the resources, but it cannot cover all the overseas development assistance that we are getting. And we are happy that they are coming to renegotiate with maybe some conditions, but definitely they will not go away completely. Thank you.
Thank you. My response may not be different from his. Still, we appreciate the government's efforts in increasing its domestic budget funding to our department, but also to the ministry as a whole. Government has improved logistics for us. Our department is a department of programs, and I usually tell people, no logistics, no programming. We need drugs, you need laboratory supplies, and so on. And from the look of things, government has been able to give us some good billions to buy more logistics, drugs, lab supplies, and so on. But also human resource, as he has said. We are seeing more health workers being recruited to help us in running our programs. But I also want to say the withdrawal of US funding maybe was also a blessing in disguise. Government has a core mandate of providing health services to its own people. It has been a wake-up call for government to increase domestic funding, and that's what we are seeing. So what we are seeing an inverse kind of relationship. As donors decrease their support, government is also increasing its support. And maybe we plan to hope that soon government will take full control of its own financing to health services. Thank you.
So let me first jump in and come back to you later. So it means, you know, WHO is global. So maybe back to you, Chris. This question may not apply to you directly, the increment in the government funding. And maybe last week I was reading a paper called Dangotelization of Africa, coming from the word Dangote. Dangote is the richest African man, the Nigerian. So this guy has put an, you see, many of the African countries, the NGOs, civil societies like Chris, apply for grants abroad. They go to those top richest American, top richest guy in Europe and in Asia. So people are trying to borrow from Dangote, who is a very rich guy, but has put a significant proportion of the wealth from the Dangote investment to support healthcare services. Where even local NGOs in Nigeria, and now they can even accept proposals across Africa to get money from Dangote to support. The way you can go for Warren Buffett, you can go for this IT tech, and so on, to fund some of these projects in Africa and maybe program. Are you also seeing how to borrow from that in the context of Uganda? We have a number of rich people in Uganda whose value of money up to trillion money, which you feel could be in excess of what of their needs as individuals. And also you're seeing industries that are domestic and also international but based here. You're seeing bodies like MTN and Airtel. Can they be approached, or is it a way where you can feel like there could be a room where you can use as a mitigation measures against inflow of money from the external sources to support programs within Uganda?
Thank you so much, Joshua. We would actually also want to, if there was some body willing to fund the the NCD services, prevention and control would want to go into that, to venture into that and get those funds and maybe provide the services. And we do not have very many of that type, but also as Ugandan NCD Alliance, or the NCD Alliance movement, we are a bit skeptical on who funds our services, because we know some people probably are people who promote the risk factors on NCDs or some kind of funding and wouldn't want to get sources and wouldn't want to go into the sources and get money from them. So we are very, very cautious when we are looking for funding. I would say like we are like a poor man in the village where I come from, but with dignity. So we want to maintain our dignity even as we look for resources. But again, I also wanted to mention to the first question that you gave to those of Gerald, that the government has increased funds in nominal values, but in terms of percentage, it's not increasing. And of course, we have also seen it has caused the trouble. As much as there is a lot of money that has been put in place, but in the health system, but if you go to the facilities down, actually, that's when we realize actually that the money didn't cause any change. The challenges haven't changed, they continue even becoming even worse. Part of the money, you know that the salaries of the healthcare workers has increased, but when you go to in terms of performance and delivery at the facilities, they still continue doing the same thing that they were doing. Would want, instead of maybe looking at, government should revise and see where they didn't put the money. Thank you.
I want to clarify your question to fit your context. In the presentation and what you have mentioned earlier, there's a kind of efficiency measures, a lot of trade-off, where you find some interventions are being put down while others maintain and so on. But at the same time, the country where you are in, you're seeing some degree of increment in funding. Can it be helpful for the WHO now to say, because what you're pushing down, it doesn't mean they're not important. They're very, very important for the health sector, okay? But just because of lack of money. Can there be deliberate intervention? You think WHO can push for the Minister of Health to take up now some of those activities which you said were very relevant for WHO to do, because they're doing for the country at the country level, that they are now funded, managed through the health sector budget? Yes, as a way of responding to the aid card that has affected the WHO, but WHO reserves some of the one which they feel could be of a global nature in translating a global instruments, recommendations, capacity building, which you feel the country may not.
Okay, thank you for that question. And indeed, I wouldn't say we've developed a clean transition strategy, but we've had these back-to-back discussions where we have, handed over some of the very critical things, and government now has picked them up, especially around epidemic outbreaks, because that's actually one of the areas that's getting very affected. Because the way emergency budgets work, the money is not just sitting there waiting for an outbreak to happen. The outbreak happens, then you mobilize the money. But the preparedness aspect, by the time the outbreak comes, you should find your system prepared enough. Now, those are the activities that we have, transitioned to the government to start picking up, building surveillance systems, building data systems. Those we are, working hand in glove with the government for them to take up the bulk of those activities. I really wanted to make a comment on your question to the other two colleagues of, can the increase actually fill the gap? I don't even think that the goal here should be to try and fill the gap, because the gap that's left behind is almost insatiable, and it included things like USAID's 4x4 cars and their rent and their expensive labor. So some of those things, we don't expect the government to try and pick up the gap left there. But so the goal should not be that they are matching dollar for dollar. The goal should be that even as the money is increasing and all these supplementaries are coming in, it's doing what Dr. Krizar was saying. It's coming down all the way to the real benefactor, and that we are closing all the inefficiency gaps along the chain. And here, when I say inefficiency, I'm actually just meaning corruption and leakages in the system. Because it doesn't matter how much more domestic money we are able to bring in, or innovative money we're able to bring into the sector, if it's going to suffer the same fate which the current money is suffering, we may as well not do it. So firstly is to just look inward as a sector, and second, we address all of these inefficiencies which, as Dr. Mtunji was saying earlier, those are in our purview and our remit as a sector to address. Can we address those things so that when we bring in more money, it's actually doing what it should do? So I think I really wanted to add that point as well. Thanks.
Thank you. And Chris and Christabel are very right. We need to change some of those inefficiencies. And we are not keeping quiet. For example, the supply chain has been electronized. It's now electronic, and we can trace the drugs until to the end user. And I must say that the drug availability has improved. It's not yet where we want to be, but it has improved over the years. And some of the privileges have been plugged. Yesterday, the Health Unit Management Health Monitoring Unit of State House was presenting, and they have caught some thieves, and they have secured some convictions, and they have saved the government some resources. So the issue of corruption is being fought, and all of us, I always tell Chris that I don't want the blame game to say, you government, you are not doing this, you are doing. All of us can support the government in those strategies to be more efficient. One way of being efficient is here to go electronic. In our records, in our supply chain, I think we shall be there. We are taking some steps at least. Thank you.
Okay, thank you so much. Now the last two questions are going to put them in one round due to time. For each of us, what you see, you have some strategies that you have put in place with certain specific objectives for each of your entities. So the question is, what means have you devised to ensure that the objectives of your department are met despite the funding gaps? And two, the two-in-one questions. What should be the role of the other partners that are still holding hand with us? One of them is coffee. And maybe other country that's giving us some support through different entities. What should be their role now in this situation? Should they continue with the way they've been funding as it is, or there's some critical area that they now need to allow their resources to support the government, maybe to ensure a future sustainable health system? In the same fashion, we start with the commissioner, but finally, after the round, commissioner will conclude. Commissioner NCD, because it's the most least funded, based on my knowledge. He can reject that if it is not true. The most least funded entity under the Ministry of Health.
That's very true. But I think I had alluded to this question. What are we doing different given these cuts? And as I've said, is to be more efficient in our activities. And I said integration is one of them, but also health promotion and disease prevention, but also working at the grassroots level, at the community level. And therefore, if Kofi and other partners who are still with us to support us, they should support our strategies. I was talking to Kofi. I was saying we have this strategy of choose community health extension workers. They could be a game changer because they can go and screen in the communities. They can do health promotion. They can do a lot. But we've trained in about 30 districts. Because of resources, they can support another 10 districts. That would be something substantial. And let our partners here who are still standing with us support us in health promotion, disease prevention, and early detection. And that's why I'm happy with Kofi. We have a project with them. They're emphasizing cervical cancer screening. And I've been telling them, everybody with the cervix has a breast. Why don't we also look at the breast? So that we catch these conditions earlier. Yes, I've been telling them, don't rush to the cervix. First look at the breast. Why are you rushing to the cervix? Perpetuate the breast as well. So if they can support us so that these diseases are detected early, we shall have less who go to Uganda Cancer Institute in stage 4 and they need expensive treatments and follow-ups and monitoring. We shall have few will be going to Chirudu for dialysis. We shall have very few will be going to Uganda Heart Institute for those expensive interventions. So support us in community sensitization, support us in early detection and management at the primary health care level. I thank you.
Yeah, thank you. Again, I think the question has been answered during the different discussions. But as a department, as a ministry, I think the most important word we have right now is integration of services. We've done it with the silos implementation where you had TB clinics, HIV clinic, hypertensive clinics. Now we have chronic care clinics. When you look at communicable non-communicable diseases, for example, we know TB also is among the causes of non-communicable conditions. If you have TB of the lungs, you are likely to get lung cancer, for example. You are going to get COPD and so on. So we have to integrate our management of different diseases. When you go out for outreaches, for example, immunization outreaches, also look for someone who may have TB, do contact tracing of TB patients. Carry HIV medicines for people living with HIV. That's how we are integrating our activities. But number 2, we also decided to go virtual. In terms of meetings, in terms of performance review meetings, normal meetings, but also performance review meetings. And these meetings are integrated. Sometime back would go as TB program, you have your performance review meeting in the region or even at national level. But now when we go as a ministry. We don't just go as a disease program. We have what we call multi-sector accountability framework. We are bringing on other non-health players. For example, we need religious leaders on board. If you're going to raise awareness about cervical cancer, about TB, you need a pastor to talk about TB in his sermons. You need a bishop to talk about HIV prevention in his sermons. So we are involving other non-health actors to help us move our agenda or our strategic plans. But also, I think he has talked about disease prevention and health promotion, very important, but also community-related activities. And we've seen it, for example, in TB. There's a program we call CAST, Community Awareness Screening and Testing, where we go house to house looking for patients of TB. And we've been able to find so many cases of TB. So if there is an area we want, where we want support from coffee, is also community-related activities for TB and other infectious diseases. But also, as I summarize, I see time is not on our side. We need coffee to help us fund some of the areas which were deprioritized. I talked about surveys. We would want to know our prevalence of TB and other infectious diseases in Uganda, and we don't have the funds, but we think coffee can come on board and support us. But most importantly, let coffee help us in strengthening systems for sustainability. Most IPs have been working in silos, putting parallel programs, work with the districts, strengthen district structures so that we have sustainability of our intervention. Thank you.
Thank you so much. What are we doing different? I think we've learned that we can be efficient if we, I don't want to call it centralizing our efforts, but we want to consolidate and concentrate on the areas where we think we can maybe implement activities or do our work at the national level, but be able to fund it across the country and be able to communicate to the country. One of the things that I've done is, since we're an organization that's based using, we are based an advocacy organization and creating awareness on NCD risk factors and NCDs, we have tried to use the media so that you can talk to the media, and through the media, and you reach all the corners of the country without going everywhere. Then the other issue is that we have also concentrated on the funds that we have, that we come up with the best results. When we communicate to them, especially on our website, we basically get, we're able to attract other funds. Surprisingly, since the executive orders came, this says that only year that UNCD has got quite more numbers of calls for grants, to apply for grants. They are small, but they make us run and create an impact. And I'm also calling upon some people, if you know you have small grants that are not in big millions of dollars, please bring them to UNCDA. Will give you good results and will support Ugandans. Thank you.
Okay, so from our side as WHO, as I already mentioned, we've gone leaner, we've redefined our priorities in consultation with the Ministry of Health. We've gone more strategic now, very strategic, less operational. I think those are the critical things. Efficiency is really what the colleagues were saying. We've also gone very digital now. A lot of the virtual trainings, a lot of consolidation of different program-specific, more to holistic approaches. We are fully behind the integration agenda. We are part of the architects for the integration framework. So for us, we wholeheartedly believe in the efficiency agenda. In terms of what other partners should do, especially Coffee and the others, the first thing for me is alignment. Now more than ever, we need to align to what the government has identified as priority. And I remember in the earlier panel, somebody asked how Coffee will prioritize, and they said, oh, sometimes it's the donor's priority. I think that's completely not the way we should go. I think the government should highlight what partners need to do, and partners need to follow that to the T. Because now more than ever, we need this aid to go and stretch as long as we can stretch it. So let's be aligned to what government has prioritized. Number two, let's use government systems as much as possible. If you can't put money on the IFMIS and the PBS, if you can use the DHIS too, not if you can, prioritize that. So that if you realize there's gaps here, strengthen it so that it gives you the outcome you want as the partner, but also it's a big win for the government. So use government systems, align, blend your money. I think there's evidence that when you force the government to match your investment, there's going to be sustainability so many years down the road when you're no longer here. So blend the money, integrate. Please, I think the silos should just end completely, and let's prioritize, as Dr. Mtunji was saying, disease prevention, health promotion. Thank you.
Thank you so much. Thank you so much, team. So we want to hear now from the audience briefly before we break for lunch. If you have some questions to give to the panelists, or you have just comment to make, Dr. Kakungulizia, I'm moving the mic around.
Maybe some comments to make, particularly looking at my component. And I thank the team for having done a lot, especially looking at areas of impact. But what I would like to say is that maybe I have a different perception on the lab, where the lab, the funding has the effects of the lab, especially when we have been operating. One, HR as indicated by the program, the Assistant Commissioner, but also commodities, where we have been receiving commodities from Global Fund and the PEPFAR. Those has been affected, and they has affected a lot of provision of services. Another issue that has come out clearly is the sample transport system, whereby IPs were supporting the sample transport system, and they were destabilized. That one affected the turnaround time of samples that were coming at the center. It affected the component of results return and how the things were done. And then the issue of surveillance was talked by the WHO. It came out very well, surveillance. It was affected. And then the equipment procurement and management. Like he said, the commissioner said, the Global Fund was procuring some commodities for us, especially the equipment and many others. It was affected, and many others. Then the issue of coverage, like when you look at sustaining the gains that we had achieved during HIV program, we had reached 95% coverage of HIV. Now, when you look at the data, we are at 90% coverage. That means the effect has been much, especially on that side. And also the component of EID, how the children have been being supported on a EID program. There has been some challenges on that one. Then also data management has indicated. But what the lab has done is to look at what are the innovative ways that we can have to have some gains come back on board. What we are looking at is how do we do this efficiently and having some innovations in the system. Some innovation that we look at is coming up with the business plans as a lab. Can we have some of the activities that we do being financed, like we have equipment maintenance and calibration? Can we go to the private sector and we get funding out of that? If we are maintaining equipment, calibrating equipment, can the private sector come in and we're able to have some income from that? Then also quality management systems that we're having in place. We are now producing panels for countries outside Africa. Can we have that one as one of the income that the country can have to have this? The other components, integration, they have talked about it. But also what we need to do maybe with the coffee is to look at supporting the sustainability of the projects, of the programs. Instead of giving me money to do this, why don't you give me funding to make sustainable programs that can put in place to make sure that I continue working for sustainability? That's what I could have.
I think, thank you very much. This one is a general comment around the staff that you had who are working with Ministry of Health through USAID programs. So I think maybe this could be a recommendation. Generally in Uganda, HIV has been one of the most successfully implemented health service delivery programs. So in the re-recruitment that is actually going to happen, maybe it would be nice if recruitment is going to be done, maybe the health workers that were actually champions in providing HIV service care would be the top priority, because the objective of reallocating this money is to see that it's improving service delivery, or we are having better universal health coverage. So maybe a recommendation would be the health workers who are experts in HIV service delivery would be the top priority, and then see how to integrate them in. And then when providing both the HIV care, maybe the diabetes and hypertension, they could actually champion the integration of care. Then the second one around local philanthropy. I'm not so sure on if there is any, under the Ministry of Health's public-private partnership. I'm not so sure what the pool looks like, because COVID-19 brought in very many local philanthropists. I saw Sudir, I don't know how much he donated, and so many people, even children. I actually didn't donate, but I was surprised to see very many people donating. To what extent are we exploiting that pool of donors? Do we have some kind of like database? And is there a way to pull them in to see how they can find ways to increase the resource pool such that you can provide better services and have more money to provide services to different people within the country? Those are my general comments. Thank you.
Thank you so much. I'm going to speak a little bit different, especially following my background as a surgeon. When you look at public health services, it's supposed to be free, but there are several studies that have been done which shows that accessing surgical services is very difficult, and out-of-pocket expenditure ends up making people extremely poor. Now, when you look at Ministry of Health, they have all diseases departments: TB, malaria, HIV, cough, diarrhea. But I don't see surgical services falling somewhere. Could this be the reason? And if it is the reason, is there a way we can have surgical service department within the ministry? there has been talks about that surgery is actually expensive. But when you look into details, offering surgical service is cheaper than giving vitamin A supplementation. So how can we find a way to make surgical services better and less expensive to the population? Thank you.
Hello, this is a comment and a question for Christabel from WHO. So from some of the data you showed us, you highlighted that Uganda was at 47% and Kenya was at 52% for their public expenditure. But, okay, so something was not making sense to me in that when we talked about the out-of-pocket, to me, I feel that the lived experience of Ugandans is really horrible when it comes to out-of-pocket. So I don't think we can make the argument that the Ugandan scenario is okay. Because just like what he's saying, we have people having catastrophic expenditures when they're spending their own money and people having to sell their cows, having to sell their land to get life-saving treatment, or sometimes even just to get basic treatment. So when we come to maybe the civil society people, Mr. Kwizera and his group could also speak to that experience about the out-of-pocket experience. Because I'm sure it can be quantified, it can be qualitatively described. So maybe some indicators would be how many times are drugs listed as out of stock on people's prescriptions, how many out of stocks are the public hospital pharmacies giving to patients where they say out of stock. Another example would be in the lab, how many times are the lab machines breaking down, how long are the periods when they're broken down, how long are the CT scans broken down for, how long do those repairs take? All of those are coming into out-of-pocket experiences for the patients. So the out-of-pocket is a very negative experience for the Ugandans. So I don't see that comparison you're making. Maybe you need to explain again the comparison between the 47% for Uganda and 52% for Kenya. And maybe the scenario in Kenya, yes, they're using a lot of money, but it's being used in corruption and it's being used in a bad way. That doesn't stop the idea that Uganda may need health insurance of some form or something to reduce on those catastrophic expenditures and the out-of-pocket expenditures of Ugandans.
Okay, thank you so much for all the questions. Now in terms of response, we are going to do the reverse. We are going to start this end, and then Dr. Motunji will conclude on area which may be left out as the most senior government representative here on the panel here. So let's start with Kwizera, Christabel, and then we go the other side.
Thank you so much. The issue is on the out-of-pocket expenditure in line with what Christabel presented earlier on I think it was on national health insurance. Ideally, when she presented, I didn't make a comment. I didn't have an opportunity to make a comment, but her fears and worries are mine. I am not in for the national health insurance in the status that it is in as of now. And I think something has to be done better for us as Uganda, as a country, to be able to implement the national health insurance. The challenge is, even when you pay the money, where are you going to get the services? The facilities remain the same, and the healthcare workers' attitude remain the same, and therefore you're going to put in the money, and this money will find the way where it gets its, where other monies have always gone. So I think we need to first organize ourselves. Now going back to the out-of-pocket, I think every person here in Uganda, whoever, it doesn't matter the socioeconomic status you are in, if you are diagnosed with a chronic ailment and you have to pay for from your own pocket, you have actually started your journey to poverty. Either you are going to get poor services at the beginning, and then as you continue, and then the disease will complicate. So eventually you come to a point where you have to overspend. And that's why many times we have been monitoring. Every time people start from other facilities, I mean these posh facilities around the town, eventually at the last stage, they end up in public health facilities. And that's why you have, most of them have died in the health in Murago. Even when they are being referred out of the country, they are from Murago, because they have gone a downward trend from the time they were diagnosed, if they are not diagnosed when it is late. So out-of-pocket expenditure is a real problem, driving people into catastrophic expenditure. There is no actually clear line between the catastrophic expenditure and out-of-pocket if somebody is living with a chronic ailment. So we need to find a way of managing this. If you're spending money from your pocket, managing a chronic ailment, and you do not have a long-term plan, the plan must be you have a source of income, you have an insurance from a community insurance, or maybe government is providing the medicine so that you can afford and support, and probably, which is subsidized, then everybody is prone to that. And I think it's high time government thought of saving the citizens from that. Thank you.
Okay, thank you. And I think I'll pick up from his point and respond to your question. Firstly, on the catastrophic health expenditure. One, we are tracking this number, and it's there. So we have catastrophic health expenditure indicator. For Uganda, it's 13.6%. That means 13.6% of Ugandans are faced with catastrophe when they seek healthcare. And that translates to about 7 million Ugandans. So that number, we have it. We're also tracking out-of-pocket expenditure as a proportion of total health expenditure, and I presented that on the slide. Now, what you misconstrued is the comparison for Kenya and Uganda. What I was saying was on Universal Health Coverage Service Index. So it has nothing to do with the money side. So how we track UHC, we track it on two axes. One is access, so the service coverage index, and that's the one I was referring to. And the other arm is financial protection. So for financial protection, we look at catastrophic health expenditure, we look at out-of-pocket expenditure, we look at impoverishment. But back to the first point on access, Kenya's Universal Health Coverage Service Index is 52%. So that means they have availed their essential healthcare package of services to 52% of the population, while Uganda's index is 49%. The regional average for Africa is 47%. So what I was saying was that we are investing just a quarter of the money that Kenya is, but we have very comparable service coverages. That's the point I was making. So to mean the insurance, for instance, which Kenya has, is very expensive for you to even just collect the premiums, and yet at the same time, it's not giving you the outcome that you want. So sometimes people equate insurance to universal health coverage, but the two are not the same at all. And in fact, some evidence suggests that when you have insurance, you introduce a structural barrier to access, because now people need a card to access services, which right now, in our instance, in our context, we don't have that barrier at all. Anybody can go in and see a health worker. So that's why probably we have higher service coverage. Now, the problem is that they might go and even get a diagnostic and see a doctor, but they'll have a stock out. So we've tried to look at the catastrophic health expenditure drivers, what is at the root? And so we've asked the questions that you've asked. And what the analysis shows is that 50% of our catastrophic health expenditure is due to buying drugs from drug shops. So for us, the problem for financing indicators, they will always be off if we don't solve the stock out problem. As long as we have stock out problems and supply chain problems, we are not ever going to have a good health financing system. And so, yeah, that's really what I wanted to clarify, that the point is not that we should have, first of all, having insurance is going to increase out-of-pocket expenditure, because now all of a sudden every Ugandan has to pay premium, which right now they're not paying. And like he was mentioning, that does not guarantee that the quality of the service is going to change. So there is
It's very convoluted, and when you look at really the drivers of poor financial protection in Uganda's health sector, at the root of it is stock out, the second is transport costs. So I wonder how insurance is going to solve the transport cost. It's most likely not. So that problem will always be there until government is able to build facilities in every 5-kilometer radius. Thank you.
Thank you. I think most of there were actually recommendations, or yeah. I think they're just 2 questions. The rest were just comments. The gentleman who raised the issue of considering HIV experts when it comes to recruitment. I don't know your background. Probably you must be an HIV expert. But I want to tell you that because of vertical disease program implementation, we created experts. Experts in HIV, experts in TB, experts in what, and so on. So our health workers were looking at patients in terms of diseases. I look at you as a patient of TB, HIV, and so on, forgetting that the same patient who has TB most likely is also going to have HIV. HIV has exposed him to, has predisposed him to getting TB. And we know TB is the biggest cause of death among HIV patients. We forget that the same patient who may have HIV could also be an alcoholic. And maybe because of DC inhibition and other things, he was exposed to getting HIV. So we don't want to target particular cadres, HIV experts, TB experts. We want to target people who are able to provide comprehensive health care. Let us look at patients in totality. Comprehensive, let us not look at patients who have with diseases. Let us see patients who have got a disease, but not a disease in a patient. You get it? Instead of looking at someone having someone as HIV, let us look at him as someone who has got HIV. And then look for other conditions that may be predisposing that person, but may also give you poor treatment outcomes. So for us, I think the minister will recruit people who are competent. When we are being trained in medical schools, nursing schools, we weren't trained as TB specialists or HIV specialists. We are being educated, we are being trained as healthcare workers to provide comprehensive treatment, and that's what we want to go to. My good friend Omona, the surgeon, surgical services in the ministry, and you are advocating for the department. I think surgical services are catered under clinical services, if I'm not mistaken. And if there are any issues that you want to advance forward, we have a whole department with a whole commissioner. Thank you.
Thank you very much. And my colleagues have attempted to answer most of the questions. I have another engagement at 3, so don't worry. I will not speak long because I will be more affected than you. Yes. Somebody was asking whether we monitor things like drug stockouts, laboratory supplies, when equipments are faulty and somebody has to. Yes, we do. And those indicators are there, so we follow them up. It's only that maybe we don't know how to drum our successes, but we do. The issue of local philanthropies, whether we have a list of them and whether we are actively engaging them, I think that is a department for partnerships and what. I'm not sure whether they have enlisted the local donors, but I know they have developed a digital tool that is going to track those who who invest in health, and maybe it's a feedback to give them that what about local people. The lab issues were mainly comments, but I was in the review and we talked about how to bridge those gaps. We know, by the way, some of the indicators, as my colleagues presented, have started reversing or declining. And I was concerned when they were talking about HIV, that mainly now it affects the young people, 24 years, 19 to 24 years, And you know, men like such a group of people. So we are concerned. But I'm sure that, you know, we shall find some money, some partners, and reverse those trends and regain our gains. You know, is now protecting our gains. Lastly, I want to end by giving you hope. Don't look, you know, so discouraged and as if Uganda is going to get finished because USA has cut funding. Don't. Money is coming. Money is coming. Our oil is about to flow. The minerals, we are finding more minerals. So if we plug the corruption issues and all that, money will come and will take care of our population. There will be some challenges, as usual, but don't worry, money is coming and we shall take care of our population. At least even when the cutting was there, HIV patients were still able to access drugs. But the issues of transport and those other things, those will be handled. I just wanted to end on that positive note. Don't worry, money is what? Is coming. Thank you and bon appetit.
Thank you so much, our panelists, for the wonderful contribution you have made to this discussion. I think our team who are rapporteuring have taken the note of the priorities and then where our partners should put more effort in terms of supporting their sector. At this juncture, I invite you in front. We take some group picture. Our cameraman, let's also enjoy what the rest enjoyed here. We have at least a picture with this team in front here. I think it should be up here. The cameraman.
Dr. Mona, I will request you again to help us with the picture here. You have a very nice picture. Yes. They have just dissected very well a topic, so give them a nice picture. Thank you so much, Dr. Jetho, for such a wonderful moderation. Let's give a hand of applause to our panelists, please. I'm sure we are all now very conversant with healthcare financing in Uganda. I would like to welcome the representative from the Korean Foundation for International Health, Uganda, who is a senior advisor on official development assistance specialist. He's an ODA specialist, Mr. Jung Sang-hoon. You're welcome. And I would like to humbly request you that we listen to him before we can go off for our lunch, just for a few minutes, and then we'll be out of here. Mr. Jung, you're welcome.
Thank you. Thank you. Good afternoon. In the face of lunch, the briefer the better. So my name is Sang-hoon Jang. Actually, I'm working as senior advisor, as introduced, senior advisor come health program specialist. I started my career here about less than 2 years ago. Actually, before I joined COFI, I spent most of my time with KOICA, more than 35 years as a four times country director, including Nigeria. And this is, restart my career here. COFI is, for me, is a very new area and with a new working environment. For me, working with the Ugandan friends, it was as a kind and heart, warm, and as the weather here. So I was very impressed by the weather here. And then actually with the Sarah, who is a scholarship, Lee Jong Fellowship Scholar coordinator here, we have a very close, consultation and, to draft out some unique and very innovative KGA project. Fourth, this is actually second, era to develop a new kind of framework. For me, this is For example, last year we have actually made some very open competition to the KGA project, where more than 24 proposals we have come to this our desk. So we select 3, even 4. This year, because of too much difficulties in coordination and sorting out the project proposals out of the we have to select only 4 projects out of 24 is not easy, So this year actually I myself create 3 pillars, 3 framework. One is research, another one is e-contents, another one is health forum, coffee health forum. I designed this health forum. Even I remember that I designed myself the topics. One topic is I just try to include as maybe it can be chosen by our office. Maybe second day, maybe chosen by the Ministry of Health. And another 3, because I'm designed in a way 3 days it should last. So last day maybe it will be decided by in good consultation with among the key stakeholders, including Coffee Office and KJ Executive and the Ministry of Health or whoever. Especially from that perspective, for me it is a very meaningful. But I just want to explain this background because I have a good expectation that this Coffee Health Forum will be continued. Even personally, I'm planning I'm scheduled to leave this country, in this beautiful country, on the 23rd of December this month. So this will be my last participating in this occasion. But because this is some of the framework, I want to continue it even next year with the different people, more professional presenters, and I want to make it some international coffee health forum where coffee has some offices, even Koika has some offices. You can invite some good presenters, to expand your networking, also deepen your knowledge. So for me, in principle, I used to say, and repeatedly, if you have built up your own castle, kind of closed, in making a closed kind of forums, you cannot learn from anything. But if you can, destroy the castle, and if you make it open, then you will find a lot of new ideas, new technology, new people will come, so that you are the person who are enjoying the learning and knowledge. So I really wish that this, Coffee Health Forum will be developed into a kind of at least East African global networking, where as a knowledge generator, especially leading forums focusing on health, of course. So I think that's even though the number, maybe you can, even if you make some teleconferencing next year, so in that case, the number is not important. I really always believe that the intensity of our determination, also solidarity, is most important. And then by taking this opportunity, especially the executive KGA directors, executive directors of the KGA, also the participant here, is a really an valuable, opportunity to meet together. It's about networking, of course. Especially that Dr. Omano is who is very active in the developing or even help this KGA forums. So I trust on that. And then sorry for, I should have come earlier, but today we have very urgent business, including our new country director. I know the country director is leaving for kind of maternal leave today. So we have some so much unfinished business, so that please excuse my late coming. So anyway, it is very meaningful and valuable, and the future is depending upon your determinations to make it based on the openness and the professionalism. I believe that this will be a really wish to see a global networking forum on health. So Congratulations again, and thank for organizers, and thank you for your participation. Thank you very much.
Thank you. It's time for lunch. I think we'll break off for lunch. When we come back, we still have one more program to be done with, and then we'll call that a day. Can I ask someone to pray for our lunch? Any volunteer in the room? Someone take the opportunity? All right, let's pray. God, we thank you for this day. We thank you that you've been able to bring us this far. We thank you for the lunch that you've prepared for us. As we enjoy it, we pray that we benefit from it and then be back here in time for the next program. In Jesus' name we pray and believe. Amen. All right, let's go for lunch.
9:30. On the ambulance 8 and 9:30. On the ambulance 8 and 9:30.
Good evening, everyone, and welcome back from lunch. I think we might be here for just one more hour, so we can start with our last session. In our last session, we're going to share 3 tables according to what you'd want to identify with. We'll have one table with people from emergency medical services. We'll have another table with people from infectious or communicable diseases, and then one table for those ones from non-communicable diseases. And now, if you are not directly linked to any of those categories, find somewhere where you think you can contribute, or you might find a table that has less people, and then you contribute to those. So we will have some markers and some flip charts to record the discussion you're going to have. And then finally, at the end of the day, you'll choose a representative to come and present to us what you'll have agreed on. And then we will have team leads on each table. Dr. Jetho will take on the non-communicable diseases, and the other 2 leads, we're going to communicate them as soon as possible. So, Dr. Jetho, is that where the non-communicable diseases have chosen to stay? Okay. Where the emergency medical service is going to sit? You are here? All right. Infectious communicable diseases are going to come here. Hey, why are people running away from your table? Infectious here. Infectious here. NCDs, emergency medical services. We need people seated in 3 groups. I see only one person from infectious communicable diseases here. Yes. Infectious on this table. Yeah, please kindly sit on this one. Oh, infectious diseases are many. Let's use 3 more minutes. Yes, diseases wants to start. Ladies and gentlemen, I think let's wind up. Infectious disease wants to take number 1. Who is taking number 2? Yes. 5 are too many. I will give you 2. Thank you so much, ladies and gentlemen, for the discussion. EMS team, I think we're going to start with the infectious disease, then we'll do NCD, and then we'll do EMS. So not to waste any time, I'm giving this microphone to the ID team to take on.
So, good afternoon, or good evening, I don't know. Good evening, everyone. So, this is what you have agreed with all of us here. This is part of your information we are presenting here, so you listen to yourself. This is Richard, you're hearing me? Okay. Yeah, so this is infectious diseases, and we had the first question which was asking us to name at least 4 infectious diseases that are a burden to Uganda as a country. And of course, we look at it not only within the border, but what can cut across. And these are the ones that the team agreed to name. That is TB, HIV, malaria, and then a host of lower respiratory infections. That include pneumonia, SARS. Alphonse, I think you're getting this one very well because this comes to your side so often. These are the ones. Then we were also challenged to bring out what could be those challenges that are creating a lot of this burden or making us not to achieve well in these disease areas. And the team agreed that in as much as we were dodging to mention financing, but we realized all the other challenges we were talking about had financing had a say on them. So we named knowledge gap, especially in the community. And this one was so much with the HIV, whereby there are even people who don't know there is self-testing. Okay, so we also talked about the fragmented kind of programming. If you look at the first 3 diseases, they are almost working in silos, and also their financing comes in silos. HIV, AIDS, TB alone, malaria like that. So we're like, we need to remove that, but that's a challenge. Then we also looked at the data. All this data, because these diseases work in that programming model, the data goes to different persons. So it's very unrealistic for you to easily notice what is going on in other disease areas. And then the human resource. If you looked at in our health sector, we have a very nice structure with the numbers and all cadres, but again, we do not have them deployed and utilized in those respective areas. And then the poor advocacy. Now, the poor advocacy came from also the knowledge gap, but my colleagues might add on just in case I have not made an explanation of it well. We also have the limited laboratory capacity. We would wish that the laboratory, which is an eye for us to know what disease are we admitting a patient for, how are we managing that patient, of course the prognosis. We also need to know when we are discharging this patient, what tests have we done before we release this patient to the community, just in the case of that one who is inpatient. But again, also in the community, there are tests that we should now make sure that they are strengthened at the community model, whereby our CHUs or VHTs are able to carry out. Remember, every infectious disease starts in the community, and the effect is most felt in the community. WASH, we brought it here because it cuts in so many areas. When you look at the hygiene, sanitation and hygiene, even if you go to our Kampala, the pockets that have or harbor TB are especially the slum areas. Yes, we can say TB is in high offices, but most often TB is a disease for the poor. Okay, and then what innovations did we think about? One, the good thing, the health ministry has taken up the integration of health services, and I think it is an ongoing process whereby those disease areas, the model was picked from, I think, HIV care, and now it has been integrated into other areas. We also would wish that we decentralize the testing services so that just confirming an influenza, you know, a sample has to travel from a beam up to Kampala, and you don't know what you might be endangering along the way. How about if we decentralize and strengthen regional laboratories to do that? And then we need to strengthen the point of care or near point of care, whereby where the patient is where they get all the services and go home. Of course, we have some equipment that are helping in the multi-disease kind of testing, like the Gene Expert, which have tested so many diseases within one place. And then the data connectivity. We had envisioned that most of the data is, remember we were saying the data is in silos. It goes to different programs. So we want to see that the data is integrated and coming to a particular system whereby it is easy to analyze and make meaning of it. So the interoperability is very important. Every program comes with its own data set and would like to do it the way it is. In wastewater, we were like, okay, can we do some surveillance in wastewater? Do some periodically pick samples of water, test and know what could be going on in the community. Because before it escalates, we need to survey what is happening with the waters. And then the use of social media. Social media is good, and by that it has come to stay, whether TikTok, Snapchat, whatnot. So we could design these messages at the ministry or at different levels and make sure that we target a particular group to consume these messages, because social media is here with us. And then the local manufacturing, we would like to promote so that if we are manufacturing a very good waraji in Ilira or in Kasese, called Kasese, what is different, what is difficult with us making a 70% alcohol in the country, so that we localize some of this. We have some companies that have started doing some RDTs. We could be able to test HIV. We leverage on the money so that it is locally utilized instead of buying everything from outside. Remember, that also extends the lead time when you have ordered for an item and when you want to utilize it. Lastly, we wanted to pray to Kofi and other stakeholders that we've talked about a lot, how we think we can innovate, but how can you come in? How you come in is to give us continuous capacity building. Capacity building by either exchange of knowledge or transfer of knowledge, or placement of knowledge. I know many of us here are beneficiaries of placement. Most of us here were placed in certain institutions or universities, and the knowledge that we got is actually helping to enhance the service delivery at the points where we are serving. We also needed to collaborate through initiatives such as twinning, and there was the other, I think it is mentioned somewhere down. We need to collaborate, and this is quoted. I remember there's a colleague who mentioned it. Maybe we'll clarify exactly. And then we have to do co-financing. So the co-financing here, we were looking at if you can do performance-based, give the money or give the assistance, and then see what it has done, and then rate that performance and give more. Instead of putting a blanket and say, okay, for the year end 2026, we are giving you so many millions, and you are not checking. Maybe you're only doing baseline, midterm, and end of term. By the time you come at end of term, a lot of leakages could have occurred. And then the technical support and designing of integrated data systems, yeah, we've talked about it. Then facilitating the tech transfer, I think I've also talked about it. There was something again which was coming out. From 2014 or so, we are still relying, we have not gotten the new prevalence survey for TB, particularly. And yet TB is a single infectious disease that kills a lot of people. With HIV, I think it is almost every 2, these days I think it is every 3 years or something. I hear Ufia is telling you about, is telling us, not you only, even me, that the age group, you know, and you, as you read the report, you realize your age is also around there, where there is a lot of, you know. So we are praying that probably Kofi and other stakeholders come in so that the protocol has already been developed for this prevalence survey. And we would pray that if finance, we can know the country's burden of TB in Uganda. I will end here. Isaac Newton is my name. I thought you were able to read. That's why I didn't introduce in the first place. Yes. Thank you.
Some questions for ID. Any questions? All right, if you have no questions for ID, let's give them another round of applause. And let's listen to NCD. Put something there. Put this. Add on the thickness. Okay. Put it right. Push it.
Or we could just use tape if it fails.
Yeah. You push it under. out of your words, put it here. And then let me I think to hold. That's okay. All right.
So my name is Joseph. Speaking to you about NCDs. So the question is, what are the conditions with the highest burden of NCDs in Uganda? So we listed quite a number, and one of them is cardiovascular diseases. We gave some of the examples like high blood pressure, stroke, heart failure, and so many others. Then we also gave cancers. There are so many of them. Then we listed some of the common ones like cervical cancer, prostate, and breast. Then the other third, one of the key conditions is diabetes. We also have chronic respiratory diseases, mental and neurological disorders, and then also sickle cells. So these were some of the commonly identified conditions which we realized are contributing the highest burden of NCDs in Uganda. So the next question. Forgive the quality of the writing. This is what the best the marker could do. So the next question is, what are the greatest challenges? So some of the challenges we realized was health system response. Health system response. We realized that the health system response we have today was designed to respond to communicable diseases. So you find that when you listen to some of the programs which are doing some work around NCDs, you will hear that someone went to a health facility in a local, maybe somewhere in Imbarara or somewhere in Intungamo or Wundibijo, but none of the health workers knew that it was an NCD. So by the time someone gets to a facility where they get to know, and the reason why is basically the health system response is not designed to respond to NCDs. Second one is the latent nature of disease. You find that the disease progresses slowly, so you find that by the time someone responds, or most people take time to respond. So because of this, the politicians don't mind, most of us don't mind, and by the time we're able to respond, maybe that's when someone is collecting 30 million to go to India for an operation, and you find because of that, this is a common challenge. That's why we have always seen very many people fundraising for any kind of medical support outside the country. The third one is one of the greatest challenges is a long-term expenditure. When you get an NCD, it's not a coatem problem where you go to run to the nearest facility. Some people, we know that most or one of the people we have within the country, they do self-treatment. So if someone feels headache, he runs to the facility, or he runs to the nearest drug shop, gets coatem. Once he feels okay, he knows he has sorted what the doctor would have done. So now the challenge NCDs has is a long-term expenditure. You can't just run and then you buy coatem and you're fine. You have to keep spending year in, year out. Very many reports show these estimates, maybe $300 per year, depending on the level. Or if it's cancer, maybe $1,000 or $3,000. The fourth one is inadequate financing for NCD intervention. When you look at our budget according to the multi-sectoral plan, I think about more than $100 million US was planned for NCDs in Uganda specifically. But I don't think, or I'm not so sure, if most of this money was actually, most of this was funded by the government, because almost 75% of the budget was coming from outside sources of funds. So because of this, we have a general challenge. The second one, or the fifth one, is human resource capacity gaps. When you go to most of the facilities at local level, or even when you go to some of the private sector facilities, you find that we do not have experts who understand the different challenges. Even sometimes in the government facilities, maybe my colleagues will respond to this. You'll find you need an oncologist, a diabetologist, and an endocrinologist. Most facilities or the government can't afford to have this in almost most of the local facilities. So you find this general challenge affects service delivery.
Then additional challenges is awareness, is a general challenge in the community, also among service providers. Then the other one is the increased risk of comorbidities compared to communicable diseases. So if someone has malaria, they are very unlikely to have typhoid. But if someone has diabetes, they are very unlikely to have hypertension. If someone has, you understand this, if someone has hypertension, they are very likely to have diabetes or any other one of the comorbidities, or maybe one of the mental health challenges. So these are some of the common challenges that we realized. So this is looking at what are the innovative ways of addressing NCDs. One of the best recommendations was massive screening. The same way we do for HIV. These days when you ask anyone, what is your status, they know they're asking about HIV. So I think we should get to a point where when we ask, what is your status, there are two things. We're looking both at HIV and also maybe what is your status when it comes to NCDs. So we believe massive screening is a very, very good solution and sustainable. The second one is using multi-test platforms for testing most of the NCDs. You find that if you're going to test for maybe any one of the NCDs, you need one specific maybe strip. Then to test for another one, you need another one. So that increases on the costs. So is it possible maybe to have one system which can do, where if they are maybe to do a draw, it can test all the different respective elements, and then we're able to tell, well, this person maybe has this problem, and these are the best solutions. Then the third one is electronic record visualization, or having an electronic system which is tracking, and maybe a dashboard which is tracking the general progress when it comes to intervening, prevention, or controlling NCDs. The fourth is creating awareness of the risk factors. We know the common risk factors is physical activity, healthy food consumption, and the other risk factors. So generally, it's important that the people locally know the risk factors and they adhere to them. The fifth thing is having curriculum enhancement. Previously, the curriculum for medical professionals, nurses, was focused on communicable diseases. Is it possible? Or do we now have non-communicable diseases as a course unit, such that most of the medical workers, most of the nurses know this and they're able to actually serve patients better? The sixth innovation is integrating of service delivery, and this has been shared with by the previous group. We believe that integrating service delivery reduces the costs and improves access to care. Then the last question is, how can Kofi help solve these challenges? One of the key of the three that we developed, the first one is technical support. And this could mean maybe providing knowledge which is tailored to local needs. Maybe the needs in Korea are different from what Uganda has. So is it possible for technical support to be provided to maybe our health service providers, to our CHUs, such that they can see how they can support patients better? The second one is building capacity, as recommended by the other colleagues. Is it possible to find ways to build capacity, both through exchanges, also locally, such that we can give health workers knowledge, skills, and they can provide services better? And then lastly is financial support. And this financial support is not necessarily asking for money such that maybe the government or a civil society can go and implement this activity. The main idea behind this is the financial support should be programmatically driven, and also it should be tailored to see that we are achieving the overall goal that the country has set. I do not know the progress of the current multi-sectoral strategy. At the moment, there is a multi-sectoral strategy which is integrating NCDs to other diseases. So we believe when it's ready, it's much more easier for Kofi to see what gaps exist and then find ways to fund some of these relevant gaps, and then we see how we can help to end NCDs. That's it from our group. Thank you.
Thank you. Let's listen from EMS. Any questions for NCDs? Yes, one question.
Thank you so much, the presenter and also the group. We have seen that prevention, health promotion, and early detection of diseases help in reducing expenditures. As a country or as a NCD program, what are we doing to increase on early detection of these diseases? Also, do you think we are doing enough research to inform policymakers? Thank you.
I think starting with the first or the last bit you shared about research, there's some research that has been done. I think recently, Mr. Chris, there was a benchmark survey which was done. Then every 2 years, WHO publishes a progress monitor, which shows where we are at the moment when it comes to having the relevant policies. What it means when we look at some of the laws around taxing tobacco, alcohol. Then the first question, or the first bit you asked around if we are doing enough. I do not know if we are doing enough necessarily, but what I can say, something is being done, and more effort and funding is needed. Because when you look at our national budget for NCD work, most of the funding is supposed to come from outside the country. So because of this, you find that we are not able to implement most of the programs that we have. So we can say that something is being done, but it's not necessarily as enough as we would love it to be. Maybe Mr. Chris can add something.
Thank you so much for your question. Actually, we are not doing enough. If we are doing enough, we wouldn't be where we are. And the reason we are here is to ensure that we find a way forward. And on the issue that what should we on prevention and control, we are running the country and the rest of us to do mass screening. That's when we'll probably be able to do early detection and maybe diagnosis, and then enroll people into care and do treatment. But also looking at the mass sensitization and awareness creation, both on the risk factors, but also on the disease, that for those that have been diagnosed, they can be enrolled into care, then also strengthen the referral system and the linkages so that people can get can get adequate services and on time. And then, of course, that is probably what I can say in response to your question. Thank you.
Yes, maybe Benjamin, Andrew Sauteba is my name. I'm a manager at CPHL. Maybe just to coin it better, what Benjamin was stating, we need to take note that we still have limited diagnostic infrastructure for NCDs. You realize that we've built capacity for infectious diseases, for HIV, TB, and now antimicrobial resistance, but we still have limited diagnostic infrastructure. But then also, beyond the mass screening, we need to integrate NCD diagnostics at the primary health care level, because you'll do your health camps and mass screening, and after 3 months, what next? So we need to ensure that we have some hematology, biochemistry capacities at the primary health care level for routine access to these diagnostics.
Thank you very much. So I'm representing the group of EMS, and we are discussing on areas what others have discussed. And one of the areas, the challenges that we are still seeing in EMS, and one of the burdens that we are seeing, we are being overstretched by trauma. And trauma, of course, we can't really talk more about trauma. You have seen many road traffic incidents that have happened around, and this really puts a lot of burden on EMS. We have obstetric emergencies, and currently these are one of the major customers of the EMS services at the moment. We have the burden of non-communicable diseases, non-communicable emergencies, like the people with cerebrovascular accidents, people with heart failure, people with diabetic emergencies, but also we see the burden of communicable disease emergencies, not forgetting malaria, pneumonia, and HIV-related emergencies. Including psychiatric emergencies. So what are the challenges that we're having in addressing these in addressing these burdens. So our challenges, we have structured our challenges in 3 categories. That is on scene care, during transport, and at the emergency department. So one of the challenges on scene care that we have is that bystanders are not trained. Majority of us, yes, might be health workers, but actually when they take you to do to give first response, now when you're going home and someone is knocked, you just bypass. So we are unable to help those who get accidents. And there is no, at the moment, there is no system for activation of EMS services. If you have seen an accident, how do you access an ambulance? How do you activate? So we still have a challenge here. And we have, of course, we still have ambulances going alone to evacuate patients without health workers. So the problem, the challenge of lack of during transit care is still a challenge to us. Then, of course, our ambulances, they still have challenges of fuel, enough fuel, maintenance and servicing. Then, at the emergency department, we have challenges of course, dedicated human resource. Now, if you're given an assignment to go to A&E, next year you're rotated to maybe HIV clinic, the other year you're rotated to UNEPI. So, and when you're building capacity, for example, when you train someone, you build the capacity, someone is transferred. Now you bring in a new person, you to try to train, they is transferred. So it's really a challenge. But of course also the other challenge where we need, I think we need support, is the lack of spaces. Those who have gone to Mrago, but also and other facilities, you have seen space not enough to accommodate enough beds. You have seen patients being put on the floor. Not that we want them to be put on the floor, but we don't have an alternative at the moment. And then the other thing is lack of equipment and medicines. This one is a very, very big challenge. And then the other challenge that we haven't handled the issue of rehabilitation and integration to these patients, mostly for accidents, but also stroke patients when after they have been resuscitated and maybe discharged, the rehabilitation and integration is still lacking. So innovative ways to address these challenges. Of course, we need to train. We need to train first responders. We need to train people at the community level. We need to sensitize everyone in the country that when an accident happens, activate the system, but don't focus at steering, but support someone to live so that you can steer more tomorrow. We need to operationalize 912 and have it functional in our dispatch centers. As Commissioner said in the morning, remember the system, the Ministry of Health is focusing on developing, establishing regional core and dispatch centers across the country. So we need to see these ones functional, standing and functional. And then we need also to, we need support the process of enacting the Good Samaritan law. At the moment, some of the people, they want to help. People have been trained, border borders have been trained, VHTs have been trained, but there is no Good Samaritan law to protect them in case anything happens during their support. So we need support here. Then, of course, with the call center, we need, in areas where hard to reach, we need to be able to have a system where if maybe I call from Chisoro, let's say here in Kampala, if I call from Bwaise, for example, someone in the call center or someone in the ambulance can be able to see where my call came from, so that in case there was maybe the issues of directing someone, they can use GPS, they can use your geographical location to see where exactly you are. So we need support there. Then also during transport space, the innovative ways, we need to train, of course, professionals and have them recruited on the ambulance. We need to equip these ambulances with equipment and supplies, and then so that we can provide, we should be able to provide good care. Then at the emergency department, we need to support our health workers with skills in basic life support, in trauma life support. You have heard about Tutata that was piloted in Masaka, so we need to have this incorporated in many of the trainings, in-service trainings. We need to have our emergency departments deployed 24/7. We need health workers to be always there at any time of the day. And then, of course, if we work without protocols, we can't work uniformly. So we need protocols at all levels of care. Yeah. So then the other thing, of course, is to train the health workers on planning for medicines, for supplies, for equipment. So when we are planning, we don't need to sit alone. We need to first sit as a department, see what most of the commodities we use, and then we prioritize what we should procure to be able to help patients. And then, of course, we don't need to plan alone. We need to plan with NMS and the hospital managers. And then also the other challenge where we still have and we still need support is digitalizing the EMS data, both from the community level up to when it reaches the DHIS2. Then also we need to support hospitals with introduction of point of care diagnostics. This includes laboratory diagnostics and radiology diagnostics. So if we can introduce this, then we reduce the time when you're sent to Wandega to go and look for ultrasound. We reduce the time that you're sent outside, maybe to go to Ransom to take samples of a few things that could be done on site. Thank you.
Thank you. Any questions for EMS?
Mine is not a question, but the last point that you made is really critical. We really have a challenge of delayed access to essential rapid diagnostics. When you look at our ambulances and other EMS infrastructure, rapid diagnostics for blood grouping, cross-matching, electrolytes, HB, lactate, they are missing. So we had come up with a list of point of care tools that we deployed in the recent Ebola, the viral hemorrhagic fever mobile labs, but they are quite costly, and also the supplies being readily available is a challenge. So I think there is need for us to have some bit of thinking on how we can have some of these tools to support. And lastly, even when they are available, quality assurance is a problem. They are not calibrated. Some of those glucometers and quality controls are not available, and that has an issue to do with the reliability of results. But overall, thank you so much.
Thank you so much. Mine is a suggestion. We always see police patrols on highways. Why can't we have the same for ambulances? Is it costly? Something that we can think about. Thank you.
Any more questions? I think I should also ask one. You talked about first responders. I've seen so often on football pitches, in stadiums, someone collapses and you can really cry about how people just watch you die without even trying to intervene at all. Have you considered training the masses in how to do simple things like basic life support?
Thank you very much. Of course, on that point, Minister of Health is not sleeping. In the morning, Commissioner talked about the math gatherings framework that is being developed. So that every gathering, let it be a Chivuru, let it be like Namugongo or these political campaigns, to make sure for you to be given a permit to go ahead and hold a mass gathering event, you have provided an evidence that there will be a professional team with equipped ambulance. And also, of course, also what Ministry of Health Emergency Medical Services is doing is training the first responder. But of course, the pool is too big, and the resource envelope is very narrow. So we need a lot of support here so that we can train these first responders and equip them to be able to provide the quick response, because you're not there. By the time you come from wherever the ambulance is parked to go to reach, if someone was bleeding, if there is no one to stop bleeding, at least for example, you will find when someone has lost life due to bleeding. So the issue of training, it is something that we need, maybe, I don't know, it is something that we can tackle through, I think, institutions, maybe schools. We can't wait to train the community. You cannot train how many millions in 1 week, but if you put it in curriculum, and I think this is one of the strategic areas in the strategic plan of 2020-2025, to train, to incorporate first aid curriculum into training institution curriculums with means of education, so that by the time a child has finished primary, it knows how to provide some of these basic skills. So that is one of the areas. Then on the issue of having ambulances parked, being many as police kamangaris, yeah, it is true. Of course, we have to recognize that we have come from very far, but as we come, we have seen this one being catered for. For example, Dr. Anyai talked about the support to Red Cross, where the government procured 21 ambulances to be stationed on the highways. So, and they are given fuel, they have human resources, so that in case there is an accident, they are able to quickly reach there, but they are still few. 21 ambulances in the whole country, where maybe he talked about more than 200 hotspots that needed ambulance nearer. You see, it's a big challenge. So if we can mobilize and advocate for more resources to these solutions and have more ambulances which are equipped and also with staff, of course, with the support of call and dispatch system, because even if you buy 1,000 ambulances, but if they don't have any activation system, they will not do the purpose. So we need, as we think about buying ambulances, but also let's think about strengthening the call and dispatch centers by activating the 912, but also making it functional and available 24/7. Thank you. Dr. Kom has...
Thank you so much. I think we're going to stop here. A round of applause for the EMS team. Beatrice, I want to hand over to you, since you are the one who started the event. You'll probably tell us about the program for tomorrow. Oh, Alex is here.
Oh, actually, it's the same thing. All right, thank you so much. We all have this on our tables. Can we do the scanning and give feedback for today's and evaluate today's, the day today as it has ended? And I want to thank you so much for this. And that's what I wanted to communicate. Otherwise,
all right, as we do that, Beatrice, anything you'd like to communicate about tomorrow and the day after? You are running in the opposite direction. But otherwise, thank you so much for sparing the time and coming, and thank you so much for the wonderful discussion. Everything that has happened here is recorded. It's on YouTube. So you can go back and watch the whole 12 hours of the proceedings. And it's not being watched just by us, but also by very many other policymakers who would like to, who have the capacity to implement some of the things that we are discussing. Beatrice, you ran away from me. I don't see where you are.
Thank you, Dr. Edward. What a day. Thank you, guys. Thank you, everybody, for the work that we put in today, for all the discussions, for being here from morning up to now. We do appreciate you all. So in regards to tomorrow, we have shared a program with you. Our program still continues tomorrow up to Friday. So we would like to encourage us to come and attend all the days so that we can be able to achieve what this event is really about. Because if different people come today, others come tomorrow, then we don't know where to start from, something like that. So let's keep coming until we finish the program. So we still have lined up discussions for tomorrow, which are a bit interesting on EMS and KGA projects that have been implemented so far. There will be very good discussants, and we hope to have a very productive day like this one today. Yes, thank you so much, everybody. Yeah, so in regards to facilitation, I know we are all expecting to hear that. So we, together with Kofi, are preparing a facilitation, a transport refund. We don't have it right now, but Kofi is preparing it. We might get it at a later time. But we encourage you to come. Thank you so much. I appreciate you all and see you tomorrow. Ashaka has a communication to make too.
And maybe lastly, after evaluations, please pass by the usual place for your evening tea. Don't leave it for us, you can't finish it, please. So let's do the